Okay, question 3. Based on the various professional societies, American Diabetes Association, as well as the European Association for the Study of Diabetes, the consensus report on how to manage hyperglycemia in 2022, an increase by an extra 500 steps per day, extra 500 steps a day only, is associated with decrease in heart morbidity as well as all-cause mortality by how much? 3 to 6%, 2 to 9%, 4 to 7%, 5 to 8%. This speaker, very naughty one. All right, so let's just guess what is the right answer. 10 seconds. All overlapping, naughty. Okay, let's go to question number 4 on nutrition. Which is the following diet intervention recommended to help you lose weight in pre-diabetes? A, very low carbohydrate ketogenic diet. B, intermittent fasting 5-2. A high-fat, low carbohydrate diet. C, and D, a calorie deficit diet, irrespective of the macronutrient composition. 10 seconds. Okay, 5. Which of the following statements is true? Which one is true about diet intervention for prediabetes? A, skipping meals is a good option to reduce calorie intake. B, avoiding rice in every meal will reduce diabetes risk. C, swap rice with white bread will lower glycemic response after a meal. D, consuming plain water instead of sugary drinks can reduce diabetes risk. Which one is true? 10 seconds. Okay, 6. Which of the following strategies would not ensure a sustainable lifestyle change for the long term? A, multi-component lifestyle intervention program. B, one-on-one counseling every 6 to 12 months. C, wearing an activity tracking device such as Fitbit. D, monitoring and coaching using digital health apps. Okay, which one will not be helpful? 10 seconds. All righto, 7. Which of the following is false? Okay, everything is true except one. A, acarbose can be used to treat pre-diabetes when lifestyle modification fails. B, those with lifestyle modification had better diabetes risk reduction than metformin in the diabetes prevention study. C, initial weight reduction with lifestyle modification was greater than with metformin in the DPP study. D, the DPP-OS is the DPP extension study, showed that the onset of diabetes can be delayed with metformin, more with metformin than with lifestyle. E, the lifestyle modification is more cost-effective than metformin in the DPP-OS study. All are true except one. 10 seconds. Okay, 8. Which of the following about pre-diabetes is true? So all are false except one, right? The Indian Diabetes Prevention Study found that combining lifestyle modification plus metformin resulted in greater reduction in diabetes incidence compared to either intervention alone. This plus this, better than each of them alone. B, metformin significantly reduced the rate of IFG in the Chinese prevention study. C, acarbose reversed impaired glucose tolerance to normal glucose tolerance in the Stop Needham study. D, pioglitazone reversed new onset diabetes in the DREAM trial. E, in the SCALE study, patients on exenatide showed a significant reduction in prediabetes incidence after 1 year. Okay, which one is true? All the rest not. Try lah. Anyway, 10 seconds. At least try lah. Don't leave it blank. Okay, last. Sorry lah. Which of the following about prediabetes is true? A GLP-1 RA is the first line treatment for prediabetes because it's better at getting you weight loss. B, metformin can be initiated concurrent with lifestyle when you diagnose prediabetes. C, an obese pre-diabetic individual is a better candidate for metformin than normal weight pre-diabetes people. That means if you're obese, you will respond better to metformin compared to you're not obese. D, the dose of metformin in pre-diabetes treatment should be kept at 1,000 milligrams total once daily. E, supplement B12 is not necessary for long-term metformin-treated patients. Okay, which is true? Okay, we are done. Thank you very much. So we are now ready to listen to our first speaker. Considering that we are 20 minutes late, not to worry, we will have her talk, followed by the second speaker, and then we'll move on depending on the time that we have. Let me introduce and invite Dr. Tan Ming Yong to come to talk to us. She's a member of the Stand Against Prediabetes expert panel. She's a very experienced, well-known diabetes nurse specialist, working in the International Medical University as a senior lecturer, as well as in private practice in Malacca. She's chaired many fora with regards to how to help patients handle diabetes, and she's been involved in clinical practice guidelines as well. So without further ado, let's welcome Dr. Tan. Welcome, Ming Yong.
Thank you for the invitation, and thank you, Prof. Chan, for the kind introduction. So my talk today is on lifestyle management and support for people with pre-diabetes. This is the outline of my talk. Definition of lifestyle. What are the impacts of pre-diabetes diagnosis? Diabetes self-management, education, and support for people with pre-diabetes, and then we'll summarize. Before we come to the definition of lifestyle, allow me just to reiterate a few important facts about pre-diabetes. First, the prevalence of pre-diabetes. Based on the International Diabetes Federation Atlas 2021, globally, we have 860 million people with pre-diabetes that include impaired glucose tolerance and impaired fasting glucose. What happens if we don't do anything? By 2045 days, another 12 years, this number will have increased to 1,171 million people. And in Malaysia, 1 in 6 of us already have pre-diabetes. If we have 1,000 audience here, how many of you think that you're already possibly having pre-diabetes? Another important message that I need to share with you is about the landmark study on pre-diabetes. Since the 1990, the Danjing study from China, and then followed by the Finnish diabetes prevention study, the USA Diabetes Prevention Program, the Japanese Diabetes Prevention Study, and the India Diabetes Prevention Study. All these studies have shown that lifestyle intervention can significantly reduce the risk of diabetes, as you see across, by about more than 50%. And not only that, that is during the intervention. For long term, a lot of these studies actually have long-term follow-up. I'm just sharing with you one due to time factor. The Danjing 30 years follow-up study has shown that lifestyle intervention for 30 years still can reduce the risk of new onset diabetes by 39% as compared to the initial 51%. As you may have heard earlier, pre-diabetes is related to cardiovascular event. And after 30 years, it can still reduce the cardiovascular event by 27%. Another one is about physical activity, part of the lifestyle. In this systematic review, as you can see, it included 10 cohort studies with more than 300 1,000 participants. Just regular moderate intensity physical activity as compared to people who is just sitting down there. You can reduce your risk of type 2 diabetes by 0.31%. And out of this 10 study found, then specifically look at walking, which all of us can do. Regular brisk walking of more than 2.5 hours per week versus somebody who don't walk. There are some of our patients don't walk. You can reduce the risk of type 2 diabetes by 30%. Now let's come to the definition of lifestyle. It is from Wikipedia. It says that a person's decision to perform certain behavior that increase or decrease the risk of disease and injury. This basically in which a person how they want to live. Let's look at Mr. A. That is on the top of your right hand side corner. If Mr. A has type 2 diabetes, you as a doctor just diagnose him with type 2 diabetes. He has listened to your advice, he decided to change. I'm going to change my diet, I'm going to start being physically active. That change of behavior will decrease his risk of developing into type 2 diabetes and the risk of CVD. However, if Mr. A decides, oh, I'm just having a pre-diabetes, I'm not diabetic, so why should I change? That behavior will increase his risk of develop into the type 2 diabetes and the CVD events. Now, basically, lifestyle for pre-diabetes has 3 main pillars. One is healthy eating, healthy reduced calorie diet. Second pillar is being active and exercise with more than 150 minutes of moderate intensity physical activity every week. With these two, we hope to lose about 5 to 7% of the initial body weight for those who are overweight and obese. Now let's come to the second outline of my talk. What are the impact of pre-diabetes diagnosis? Does it empower or disempower the individual change of behavior? There are a number of literature on it. Basically, it looks at 2 perspectives. One is from the healthcare providers, impact on diagnosis. Many of you are doctors there. So how do you inform your patient that have pre-diabetes for his diagnosis or subsequent follow-up? That is very important because these are codes from a qualitative study. When my doctor said that there's nothing really to worry, it's just a sugar a little bit higher than normal, it hasn't reached diabetes. If you have informed your patient this way, then the lack of perceived seriousness will link to no change of behavior. But if you're a doctor who will tell your patient, now, pre-diabetes is serious, and I know, and the doctor has told you it's nothing, it's not funny, and you should not treat it lightly. Then you have conveyed the message that pre-diabetes is serious. So the perception of seriality will empower your patient to change their behavior. How about from the people with pre-diabetes? Does the diagnosis empower or disempower them? Well, it's both ways. If the person with pre-diabetes does not have any knowledge of pre-diabetes or its consequences, then unlikely they are going to change anything. And as we know, people with pre-diabetes, there is no symptom, no pain, no discomfort. So what should I change anything? So as healthcare provider, how do we empower them during the diagnosis? If we can introduce lifestyle intervention that fit the person's daily routine and habit, then it's more likely they will change. And lifestyle intervention where we can provide them with a lot of support, encouragement, resources, where to start to change, and lifestyle program with the concept of self-efficacy in the literature has shown that it encourages behavior change. So is this self-efficacy? Self-efficacy is a social cognitive theory that was founded by Albert Bandura in 1977. It is not about the knowledge the person has, as all of us know that we know a lot of things, but we don't do. It's the belief in his or her capacity to act in the way that is necessary to reach a specific goal. This, in a shorter form, is how confident are you in doing what you want to do to achieve your goal. Let's go back to Mr. A. If now Mr. A is your patient, you encourage him to change his lifestyle. And you just tell Mr. A, you should go for a walk 30 minutes a day, 5 days a week. But you look at his size, he's going to have he already had a lot of pain on his knee. There is something that he can't do. After 10 minutes walk, he already feels the knee pain, so he won't do. Whereas if Mr. A is already used to cycling, swimming, if you encourage him, you discuss with him, you ask him, can you go for cycling? Likely, possibly, he will do it. Now let's go back to the 3 pillars, because the next speaker will address healthy eating. For this talk, I will just concentrate on being active and exercise. Now, I would like to allow me to share with you how we can use diabetes self-management education and support process to empower our patient with pre-diabetes. The process is the same with any of your profession. There is always starting with assessment, goal setting, planning, implementation, and evaluation. So for assessment, addition to the standard assessment that we look at the clinical data, the anthropometric data, we have to assess our patient with pre-diabetes for their knowledge. Do they know anything about pre-diabetes and the risk of pre-diabetes and their current behavior in terms of dietary habit, in terms of physical activity level? And a lot of people with pre-diabetes are already overweight and obese. Many of them actually have tried with weight management, but it's just for some reason it was not successful. So ask them to share with you. And very important, do they believe that intervention for pre-diabetes will help them to improve their health? And of course, for any intervention, we have to know their motivation. So to assess the motivation, we can use the stages of change by Prochaska and de Clement in 1983. The theory that they found it. They are both, again, are clinical psychologists. For those who are not familiar with stages of change, just allow me to explain a little bit. There are basically 5 to 6 stages. The first one is pre-contemplating. If a person is in pre-contemplating, they will not change. So at this stage, you just provide them with information. If they are in the stage of contemplating, yeah, they already, I want to lose weight, but Hari Raya is coming. Can I do it later? Every time when they talk to you, there is a but. They are in the contemplating stage. Then the third stage is preparation. Some of them may think of change now. Now, maybe I have to think of how I should reschedule my daily activity so that I have a little bit of time to do some exercise. Or some of them may have gone to buy a pair of sports shoes. That is, when they tell you that they are in the preparation stage, that is easy because they are already prepared to do. And some of the patient may have come in and they may have come in and already in action stage. So encourage them. But maintenance stage, that means you have to make it into a habit. Very important is it has to be more than 6 months. You're in action stage, only you come to the maintenance stage. But life is full of temptation. Some of them may relapse. So it's important before we introduce anything, we have to know their motivation state, because that is where we discuss their barrier and discuss what are the potential solutions to achieve their health outcomes that they have planned for themselves. Okay, now let's come to exercise recommendation for pre-diabetes. Basically, they have to burn 700 calories per week of energy expenditure. How do you do it? It's very theoretical. Is to have more than 150 minutes of activity, moderate intensity physical activity. How do we do it again? You just tell your patient to do that? No, we have ways of recommending to them. Aerobic exercise and resistant exercise. For aerobic, that means you build a big muscle like walking, cycling. The frequency has to be 3 to 5 times a week, 5 days a week. For intensity, it all depends whether they want to choose the moderate intensity. That means you have to achieve about 55 to 60% of your maximum heart rate. If the patient chooses the vigorous aerobic exercise intensity, then it is just 75 minutes, minimum 75 minutes, moderate intensity more than 150 minutes. For example, for myself, I choose a moderate intensity. So my heart rate has to be 90 beats per minute. And for resistant exercise is equally important. You should have a frequency of 2 times per week. And duration per week is 75 minutes, 2 to 4 sets, 8 to 12 repetitions. Now, why is it we encourage our patient to involve in both aerobic and resistant exercise? Study has shown that the benefits of exercise will be gone in 48 hours. So a patient will say that I have no time. I only have time to do weekend exercise. That's why we need to explain that to them. And of course, very important, stop sitting down, break up your prolonged sedentary time. Now, before I continue, I'll just have a questionnaire for you. No wrong or right answer. It's just your opinion. Regular exercise or more than 150 minutes of moderate intensity per week can lower the risk of non-communicable diseases such as coronary artery disease, diabetes, cancer. Very good. Well, then you are already responding. You are strongly agree? Agree? Oh, there's somebody who strongly disagree. Okay, we'll start the pool. We'll stop the pool. We'll go back to my slide. Thank you very much for responding to the pool. You're all like most people. We all acknowledge the benefit of exercise. But we don't exercise because it just does not fit conveniently into our daily routine. Yeah, we already active. A lot of like my patients' daughter will tell me, "Mak, saya bangun tak pernah duduk. Dia buat kerja rumah, kebun, and your nurses, your pharmacy, dietitian, doctors listening to this talk. You're very active. So why should I need exercise?" So most people are just not motivated to initiate and maintain their exercise program. And our National Health and Mobility Survey in 2019 shown the same thing, the same result. 1 in 4 Malaysians are physically inactive. Physically inactive, that means they're very sedentary. So how do we motivate them? This allowed me to introduce the activity pyramid. Where you have seen the food pyramid, this is activity pyramid. If your patient is somebody who is inactive now, encourage them to increase their daily activity at the base of the pyramid. Example, walk up the stairs, park your car far away, or walk your pets. If your patient is sporadic active, a lot of patients actually are there, especially in the workforce group. They only have time to exercise during the weekend. So we have to come to the middle of the pyramid, negotiate with them. Can they add in resistance exercise or add in 1 or 2 more days of aerobic exercise such as brisk walking, playing badminton? That will help them to achieve the minimum 3 to 5 days. If your patient is already very active, very good, praise them, encourage them to continue. And of course, the most important thing is to cut down your sitting time. And this is from the consensus report from the ADA and EASD on the management of hyperglycemia in type 2 diabetes, and this can be applied to pre-diabetes. I know it's a very busy figure there. I will just bring up to you 2 important points on the importance of 24 hours physical behavior. The first one is limit your sitting time. Break up your prolonged sitting time every 30 minutes. We just get up and just walk, a short walk. Or you can, during your break up time, you can do some resistance exercise, because this has shown to improve glucose metabolism. Second, an increase of 500 steps is already associated, shown to improve 2 to 9%. Yes, help to decrease the risk of cardiovascular morbidity and mortality by 2 to 9%. Remember, it's in one of your pre-tests. And if you just walk 5 to 6 minutes extra of brisk intensity walk per day, not per week, you can lengthen your lifestyle by another 4 years. Is that good enough? And this, I'm sharing with you another one, is a New York Times study that was just published December last year. It's a UK study, 7 years follow-up. They examined the fitness tracker data of more than 25,000 people, mean age 61.8. That means they're in the workforce. Just like physical tracker data. And what they observe is those who engage in 1 to 2 minutes of burst physical activity 3 times a day. What is burst physical activity? For example, if you're late for work, you quickly go and park your car and you run to the clock in. Or if you travel by public transport to work or to anywhere, shopping or anywhere, your train is coming, your bus is coming, your MRT, LRT is going to arrive in 3 minutes. So you run for it. This is called burst physical activity. Or you run up the staircase. With just 1 to 2 minutes of burst physical activity 3 times only a day, you can reduce 50% of cardiovascular mortality risk, 40% of death due to cancer and other causes, as compared to somebody who don't know anything. So other tips that I can share is during the first 4 weeks of when you introduce a new fitness plan to your patient, don't go for the goal, but rather the first 4 weeks is for them to establish their habit and commitment to continue their exercise program. Or some people may like this table. Our patients are all individualized. They want to start slow and gradually increase. So for any exercise recommendation, they are always reading duration, frequency, intensity. As you can see, we always start with duration. We can start with just 10 minutes and eventually reach the 30 minutes. And the frequency can start with 3 times a week, then eventually reach the 5 times. And the last thing that increase is intensity. And another very important tip is whatever we recommend to the patient, you got to discuss with them something they enjoy doing. Like for me, it's walking. If you ask me to cycle, swimming, sorry, I'm not going to do it. So I may do it to please you for a short while. And very important, the patient has to believe the benefits of physical activity. For people who are big, don't emphasize exercise as weight loss, but rather exercise help to improve their health and fitness. And very important is continue to support them, to provide them with support to continue the exercise. Everything we do, there's always a barrier. Raining day and many other things. So discuss with them the potential solution and of course self-efficacy as we have discussed earlier. So how do we enhance self-efficacy? Talk to your patient, set realistic goals. Just now the slide on goals, start slow, go slow. And gradually increase the increment steps. And observe others that they can do it is another way to increase the self-efficacy. These are the two seniors that I meet them frequently in my walk, in my exercise every day. And that is one thing I love to take the senior. I really respect them. They can do it. Why can't we younger people do it? And of course, practice make perfect. And support them and discuss the barrier with them. And how do we as healthcare provider enhance the motivation? To retain your patient, to get your patient to cooperate is our rapport with them. Always have mutual trust and respect. We got to respect our patient will trust us. And when we approach them, don't use judgmental approach. We should use non-judgmental approach. If they cannot exercise, they haven't exercised since they last saw you, don't ask them, why is it you can't do it? This is very judgmental. Let's talk about it. This is non-judgmental. And very important, we must work with them to brainstorm the solution for their barrier and support them with change through patient-centered approach. Remember, every of our patient is an individual. So we have to respond to the individual needs, value, and preferences. And of course, we need to provide them with evidence-based information. As shown, as discussed earlier from the New York Times report, technology-driven interaction and wearable device has shown to promote long-term adherence to physical activity, like activity tracker, the phone, smartphone. And in Malaysia, we even have this, the use of technology-assisted program to help the patient to promote the long-term adherence. The DLP, Diabetes Lifestyle Program, that was just launched on the 14th of March. And engage your patient in this is free. And this one, they can do it at their own time. Everybody is busy through their smartphone. And of course, some of patients may change with all these interventions, some don't. So for those who just not able to change, evaluate with them using the behavior change ruler. And this one, find out how important is exercise to them and whether they are confident to change it. So this ruler, as you can see, 0 is not confidence or not important. 10 is very important to change my lifestyle and I'm confident to change it. Now in this ruler, you'll be surprised that even the illiterate patient can do it because we're not testing their knowledge. We're just asking them how they feel about it. And it's important. If those who can't, you just put on something like the example of the question on the scale of 0 to 10, how important it is for you to begin walking 3 minutes. So their answer will tell you how you can work with them. And lifestyle behavior change for diabetes prevention, the main goal is to achieve and maintain weight reduction of at least 7% of initial weight through healthy reduced calorie and more than 150 minutes of moderate intensity physical activity. Let me ask you, if the patient can achieve the 150 minutes of exercise, but they cannot achieve their weight, does it help? Yes. This study in 2006 that was published by Hammond has shown that if you can achieve exercise goal of at least 150 minutes per week without even achieving your weight loss goal, you can still reduce your incidence of type 2 diabetes by 44%. And based on the Standard of Care 2023, that is this year, for obesity and weight management for prevention and treatment of type 2 diabetes, it should be very frequent, more than 16 sessions that focus on nutrition change and physical activity and behavior strategy to achieve a 500 to 700 calorie per day of energy deficit, where they can get the 16 session is from the landmark study that we have shown you. As you can see, it's generally is about 16 sessions and more. And what is this ingredient of lifestyle intervention that actually reduce the risk of diabetes? Healthy eating, which the next speaker will address, increase vegetable and grain, reduce calorie by reduced fat quantity and simple sugar. The next speaker will address in detail. And increase daily activity and exercise to achieve more than 150 minutes of moderate intensity physical activity per week. So the take-home message, if you have not heard all the things that I've said, is okay. Only 3 take-home messages. The first, lifestyle interventions are effective in delaying the progression of prediabetes to diabetes. Second take-home message, what are the main components of lifestyle intervention? First is healthy eating, healthy reduced calorie diet. Second is physical activity of more than 150 minutes of moderate intensity physical activity every week and break up your prolonged sitting time. Third is a weight reduction of 5 to 7% from initial body weight for those who are overweight and obese. The third message you take home is effective and sustainable lifestyle intervention includes knowledge, but knowledge does not change people. So it's very important the frequency of counseling. You got to keep on empowering them and use behavioral modification supported by behavior science model that we have discussed earlier, such as self-efficacy, motivational interview, and so on. With that, I thank you for listening. Thank you.
Thank you very much, Dr. Tan. Can I just ask you, you asked the question about extra 500 steps per day, and then you can reduce cardiovascular mortality. Your answer not inside your talk, eh?
Yes, it was inside. Yes.
I missed it. For those of you, what was the answer?
2 to 9%.
Okay, so I missed it. Sorry about that. So thank you very much, Dr. Tan.
Thank you
for sharing your experience with us. With that, I think we will move on. Those of you who have questions to ask Dr. Tan, will have an opportunity to talk about it later on after the third talk. Okay. With that, let me take the opportunity to introduce the next speaker, Professor Winnie Chi. She is, again, very well positioned to talk to us about medical nutrition therapy for the individual with pre-diabetes. I won't read the very long CV, just to tell you that I know her very well from her when she was a baby, and now she's a professor in IMU, and she's done a lot of work with regards to the Healthy Malaysian Plate, and so she's really the right person to talk to us about how you should try and adjust medical nutrition therapy for the person with pre-diabetes. Welcome, Winnie.
Thank you very much, Prof. Chan. And a very good morning. I think it's almost late morning now to all our audience. Very good to see so many of you still sticking with us. And I'd like to thank our first speaker who actually set the scene already about the importance of lifestyle, in terms of pre-diabetes. Now I'm going to zoom down a little bit more about nutrition. And in the next, hopefully 20-30 minutes or so, we'll be talking about what's the best nutrition intervention for pre-diabetes. And then we'll be looking at translating these recommendations into practice, just a little bit about sustaining lifestyle changes, and finally, some key takeaways. Okay, I don't think we need this reminder anymore, but just in case you just join us for this session, lifestyle intervention, we know, leads to higher diabetes prevention rates and continues to have an effect even after 20 years. So that is the most important part. So whenever I see a patient in front of me who has pre-diabetes, this is what I have in my mind. If I can help this patient actually do better in terms of lifestyle control, I tell my patient that you're going to be able to reduce that risk by more than half. You don't need to take medication. And if you change your lifestyle, this effect actually lasts you longer. So in the Daching study, it showed it lasts up to almost 20 years, right? So I think this is very important that we need to share this message with the patient so they can see that it's worthwhile to actually make an investment in making dietary changes as well as getting more active and so on. Okay, so right, let's go into the medical nutrition therapy. Okay. So first of all, the term medical nutrition therapy. So what we really mean is that this is a process that's actually being delivered by a dietitian, but in a multidisciplinary team. Now, if you look into the boxes here, I've actually fished out from the AACE guidelines. What are the things that we need to actually focus on with our patients when you talk about their diet? Now, so the blue boxes you can see is all about calorie restriction and focusing on low fat, because that's what the DPP shows. They focused on low fat, but that was about 10-15 years ago. Then you've got to talk about proteins. You want to talk about carbohydrates. You want to talk about sugar sweetened beverages, glycemic index, fiber, portion control, meal replacements. But the more important part, underpinning all of this is actually healthful, balanced food choices. And sometimes we miss this when we focus too much on the macronutrients, or we focus too much on weight loss or intermittent fasting and so on, and we forget the basics. So this is something that I want to emphasize a bit more in my talk. Now, a lot of the patients that we see with pre-diabetes come with overweight and obesity. But I have seen pre-diabetes that are thin as well, but majority are overweight and obese. So the data that we have locally that I managed to fish out showed that the prevalence of overweight and obesity is 21 to 70, so almost 90% of patients, Malaysian patients with pre-diabetes, come with overweight and obesity. So why is that so? So I always also want to explain to patients that actually your weight is one of the things that you need to focus on. That's the reason why you're having pre-diabetes right now. And this is just a reminder, most of you as doctors, I'm sure, know this already. When we have insulin resistance, there is a compensatory mechanism where insulin secretion is going to increase. Now, insulin is, of course, as we know, anabolic hormone. So it actually leads to an increase, it correlates with onset of increased adiposity. And with that, with insulin hypersecretion, eventually there will be beta cell failure. And then if there's no intervention done on time, it will result in reduced insulin secretion and a shift from pre-diabetes to type 2 diabetes. So this condition actually is serious. So when I see a patient with pre-diabetes coming to see me, the first thing I talk to them is, look, you have to understand what's happening in your body. And one of the key things here is about your body weight, especially if they come with overweight and obesity. Now, if they're not overweight, obesity is possibly due to strong family history, but that's for another conversation later. Let's focus on the ones that are overweight and obese. So weight loss, therefore, is the focus. Now, how much weight loss do we need to look at? Now, it depends on what guidelines you're looking at. And what I'm going to show you here is the CPG for type 2 diabetes that was recently released, and Prof. Chan was the chair. So the strategies here is to look at a weight loss of 7 to 10%. Why 7%? Some guidelines say it's 5%, but if you look at the data for 7%, it's because one of the studies showed that with 7% weight loss, you actually get more than 50% reduction in insulin resistance. So that comes back to that adiposity and insulin secretion and pre-diabetes scenario, right? So you're looking at 7 to 10%, and you must tell your patient, I'm not asking you to lose this immediately, because you can immediately see your patient, oh, 7 to 10%. Now that looks very difficult. It's over time, but not too long. So let's try and achieve this. If you're very good, if you're very ready to change, 3 months, you can get that in. Otherwise, at least 6 months. Within 6 months, we should get it so that we can prevent you from becoming a full-blown having diabetes. So the strategies here is there must be talk about diet. There must be talk about calories. There must be talk about burning those calories, and that's physical activity. And then any other way that we can get that calories down. One of the strong recommendation in CPG was meal replacements. But I'll talk a little bit more about all the different strategies later. So you're talking about calories, you're talking about how much calories to prescribe. You're talking about physical activity. I think Dr. Tan has covered that very well, right? And in order for us to have a low calorie deficit diet, there are strategies. Part of it could be the use of meal replacements. And of course, you must have the behavior modification, the readiness to change. The different steps and goal setting and all that, that must be in, not only for exercise, but also for diet, more so for diet actually, because with the current environment of the lovely food that Malaysians love, it's even harder. I think it's easier to get my patients to exercise than to actually control their diet. And of course, things which is the bigger picture about whole grains, about getting enough fiber in and reducing your intake of sugars, all of that is underpins all of this as well. So, so here we are. So this is just for clarity. We're talking about pre-diabetes here. So we're looking at 7 to 10% weight loss, right? We're not talking about remission. We're not talking about people who already have diabetes. So in pre-diabetes, what we want to focus is on calories. If you follow DPP, it's about low fat. I think that's very relevant in the Malaysian setting. It's about increasing exercise and it's about behavior change. So I'm going to deep dive into this a little bit more. Now, we need to understand that no matter what the different types of diet that you do, you want to create a calorie deficit, right? We need to expand calories more than we put calories in, right? Whether you're doing intermittent fasting, whether you're going to go on a keto diet, actually, this is the principle of it. So we need to understand what gives you energy expenditure. Now, 50 to 70% of the calories we're now sitting down and burning actually comes from your basal metabolic rate. And your basal metabolic is determined by the amount of muscle that you have, not the amount of fat that we have in our body, because fat is inert. It's the muscle that's burning the calories. Now, some form of thermic effect of food. So by eating, you actually burn a bit of calories as well. And the rest of it comes from your physical activity. So this is very important for patients to understand. So how do I create that calorie deficit? Now, for the healthcare professional, you want to create theoretically 500 to 1,000 kilocalories a day. This is by paper calculation, because 1 pound of fat, if I show you a pound of fat, that's supposed to be 3,500 calories. Divide by 7 days, so you get that deficit of 500 calories a day. You lose about half to a kilo a week, or 1 to 2 pounds in pounds. But we are using kilos, so half to 1 kilogram per week. That's the rate of weight loss that you want to tell your patients to aim for. Now, if you really are serious, I mean, I know there are dietitians and nutritionists out there. So we are looking at 20 to 25 kilocalories per kilogram body weight, and you want to use adjusted body weight here, right? So the calories should come to about 1,005 calories for men. I always go the lower end because I know my patient is going to eat more. And then for women, around 1,200. That would be the sort of calorie meal plan that you want to give them. So creating that calorie deficit is about diet and exercise. That's the most important determinant of weight loss. So if you want to have your char kway teow at 750 calories, well, be ready to run 2 to 3 hours. And you know your obese patient is not going to be able to do that, right? But if you switch to something that's a lower fat content, maybe a soupy meal instead, then okay lah, 45 to 60 minutes is enough to run. But still, you got to run. You still got to burn that, right? So we have to create that calorie deficit. Now, a lot of patients ask me, how am I going to know where to find my calories? Well, there is a website. There is the Ministry of Health website, MyFCD. You key in nasi lemak, they'll tell you how much the calories are. But there's tons of apps as well. And a lot of apps now incorporate Malaysian food. I mean, I personally use Lose It. You can use Fitness Pal. There are local apps that's available, but they're probably not as user-friendly. It's much easier to just download these apps for free, and you can actually monitor that. So you get my patients to, okay, those who are, they got a smartphone, let's make better use of your smartphone. let's get that calorie app down, so at least you can begin to have informed choice about the sort of food that you are actually choosing. Now, we have to go into the macronutrients, right? So carbohydrate, protein, fats, how much of this do I really need to, what's the meal plan like? Now, the lifestyle intervention from the evidence show that they focused a lot on calories and fat. And I think for me, for Malaysians, we should do that too. A lot of our foods are actually laden with a lot of fat. So, but is there an ideal percentage? There's no ideal percentage. So dietitians out there, please, there's no ideal percentage. Don't argue with me with what I put here. These are just to make up 100%. You should individualize this based on your assessment of what the current eating pattern is, their preferences, what their metabolic goal is. So this is where, but we do need to focus a bit more on the carbs. So let's talk more about the carbs. Why do we need to talk about carbs? Because we're talking with Asian patients. And there's enough studies now, and this is a very nice study done by Professor Henry at A-Star that showed that actually for Asians, we have a higher postprandial glucose response with the same carbohydrate load, right? Particularly if you have Indian patients. So we tend to not be able to manage that carb as well as compared to Caucasian. So there's an increase in postprandial glycemic response are higher in Asians. So what gives you that postprandial glycemic response is carbohydrates. So we need to focus a bit more about carbohydrate metabolism, because essentially pre-diabetes is about insulin resistance. Therefore, it's about carbohydrate metabolism. And we now know that different types of carbohydrate give you different response. And that is about glycemic index. Now, you could argue with me whether you believe in this or not, but I think the data for glycemic index has become more and more stronger now as compared to 5-6 years ago. And in fact, a recent study that was done in Europe globally has shown that lower GI diets help pre-diabetes patients to maintain weight loss and also not progress into diabetes in these high-risk population. So I think GI is a concept that's quite familiar to most of you already. The more important part is, what do I do with this data? So this is where you then talk to your patients about switching some of their carbohydrate choices. So because we know that this is about insulin resistance. So yes, you have a low calorie diet, but what you put in there is also important. So get them to eat more unprocessed foods, because fiber lowers GI, right? Add more fiber, soluble fiber into their meals. So let them have the beans, have the legumes, add a bit of oats to your rice. These are things that I personally do as well. And it does help to lower the glycemic index. We've got data to show that as well. The other important point is proteins. We really can use proteins in a better way to lower glycemic index. And we have shown that with preload of protein, if you take your protein first, and then you take your carbohydrate, it reduces your postprandial by 20 to 30%. So it's an easy thing to do. So tell my patients that, why don't you start on your rice, start on your proteins, and make that protein lean. It can be fish, it can be chicken, it can be beans, it doesn't matter, right? And of course, at the end of the day, the more you eat, the higher your blood sugar. That is clear. The higher your calories. So please monitor your portion size. Now, of course, in Malaysia, and we've done studies to show that amongst Malaysian diet, we don't eat single meals, right? We eat it in a composite. And when meals get combined with low and high GI, so there's vegetables there together with your carbohydrate, there's protein there together with your carbohydrate, it lowers the glycemic index of that meal. Don't overcook your starches and grains, right? Some of my patients say, hey, banana cannot eat lah. It's going to raise my blood sugar. Yes, but it depends. The ripeness of the banana actually does have an impact as well. But that's probably something you want to tweak if you find that there are patients who like to take banana. So smaller portion, maybe less ripe. And then other ways is educate ourselves about GI. So know what kind of food you want to recommend. So having a lomai kai together with your dim sum in the morning finish, your blood sugar is going to go up because the GI is something like 106, okay? But if you switch to something that's of a lower GI content, even a small curry puff, that's a better choice, okay? So if we get educated ourselves about GI, we can then give more practical suggestions to our patients to help them manage not only their weight, but also their blood sugar control. Now, of course, don't sugarcoat. That's what this team is about. Don't sugarcoat our foods and drinks. Now, I know that Malaysians, we love to put sugar and salt not just salt, but sugar as well, right, into our cooking. So sometimes you see, hey, how come this dish is just a curry, but it shoots my blood sugar up? Well, the person cooking it could be putting sugar in it, right? So it's very, very important. Now, this is the men's data. Now, look at this. I think the men's data tell us a lot. We are not hot popping about Coca-Cola and Pepsi. We got to have about cordial drinks, sweetened condensed milk, our teh tarik, our cakes, our kuehs, our cocoa drinks, jams. These are the things that our patients are eating. So please do a checklist. Do you take any of this or not? And if they do, replace it. Replace it. Tell them that's the first most simple thing to do. And what I found from the literature, by just simply switching from sugary drinks to plain water, reducing diabetes risk by 7 to 8%. That's pretty good, right? So a simple thing that can be done. So please emphasize on this first, okay, when we talk to Malaysian patients. What else to recommend besides all that carb and sugar? Proteins. Proteins, I think now there's more data showing that plant-based proteins is good. It's low GI, doesn't affect sugars, but it needs to be cooked in low fat, right? Not swimming in fat, and oil. Same with our fruits and with our vegetable. Sometimes I eat sometimes in function, and you see all the veggie is very good, but it's all swimming in santan. So that's the other thing. So just go, minimize the intake of oils and fats. Besides, increasing your protein intake, things like saturated fat, blended oils. All this is also very important because a lot of my pre-diabetes patients come with high cholesterol as well, right? So we need to focus on saturated fat, and of course the ever challenging sodium, right? Which we salt everything into our diet, but at least try to get them to eat less salty food. So those things still are very important, but really the bigger picture of a healthful dietary pattern is what we're talking about now, not so much about macronutrients, yeah? So eat something, the quality of the diet, that's how I tell my patients, it's not just about how much you eat, but whether your diet is of quality or not. What does quality mean? That means you've got to have more fruits, more vegetables, more legumes, right? You can have low-fat dairy, lean sources of proteins, nuts, seeds, and whole grains. Now, if you tick the box, how many of these food groups you actually have in your diet? I won't do a poll like what Dr. Tan did, but we ourselves can reflect on ourselves. How much of our diet looks like that? So the Malaysian Healthy Plate is actually a way to translate what's on the food pyramid. And you notice we switched the food pyramid. No more criticism about why carbs is at the bottom. Carbs is now on the higher level. Fruits and vegetable is now at the bottom, although we know 75% of Malaysians don't eat enough fruits and vegetables. So we're encouraging that more. So the plate means that you put half of your plate with fruits and vegetables, well, more veggie, one fruit at the side, your lean proteins, and reduce that carbohydrate intake. Make it whole grain, because that's what we are looking for in terms of the healthful dietary pattern, okay? Now, what about things like vitamins and supplements? I know I've got patients who say I go to some of these pharmacies or even, the health food, and I get carb blockers. I get all that. Well and good, but don't forget about the bigger picture. Seriously, is that really going to reduce your blood sugar control? Is that going to get your weight down? Well, the answer is no, right? So unfortunately, well, actually, fortunately, lifestyle is an investment. You can't just pop a pill in and then you solve all your lifestyle problem. It doesn't work that way. What about sugar sweetened, non-nutritive sweeteners, right? Artificial sweeteners. I know that there's been going around in the internet scary, information coming that if you take artificial sweeteners, it's going to give you cancer. It's going to have some impact on blood sugar control as well. It is still preliminary data. So for the time being, switch to plain water. Then you don't have this issue about the safety of sugar sweetened products. But at this point in time, it is still safe as long as you don't take it. Everything should be in moderation. So if you have patients who say, I want to take some of these like Equal, for example, yeah, sure, just go easy on it, but try to train your palate to go with non-sweetened. Then you don't have to even spend money to buy those things, right? So how about all these plant-based, vegetarian, meal replacement, intermittent fasting, low-carb, keto diets? Now, I don't have time to fully go into it because that will require, a few hours of lectures. But I just want to summarize. This is coming from a summary of nutrition therapy for, pre-diabetes and diabetes. The green boxes show it works, right? So that's the most healthful diet of all, Mediterranean diet, it seems. It's about what I'm talking about, that healthful diet, right? Works for pre-diabetes. Vegetarian works for pre-diabetes. low carb with adequate support, not low carb on the patient on their own, doing it on their own, eating chicken rice, where there's no rice on it, not sustainable. A lot of my friends go on low carb, but after that I say, what happened to your low carb? What happened to your plant-based? Susah lah, cannot maintain lah. So, so at the end of the day, yes, we're not saying Malaysians should go high carb. No, you have to go low carb compared to the amount of carbs we're taking. Moderate carbohydrate with adequate support works for prediabetes. Keto diets, not there for prediabetes. In fact, in terms of nutrient adequacy, it can be dangerous in the long term. So keto diets are for epilepsy. We just talked about it just now, not for prediabetes. Meal replacement, yes, it does work. Again, sustainable or not, again, it's about the entire diet that you have. You replace one meal, but what are you eating in the next meal still matters. And intermittent fasting, jury is still a bit out, but I know there's some data showing that it does help with with prediabetes. Now, what does the guideline say? I think this is the best that I've seen quoted from ADA 2023. No single approach has been proven to be consistently superior, right? We need more data. We need to validate these meal plans for long-term outcome and acceptability. It's about sustainability, right? So, but I would say don't lose sight of this lah. It's the bigger picture, right? That great plate that we should be having, or that great bowl that we should be having. Individualize your meal plan, guides on how to achieve that energy deficit that we want, and consider the personal preference and the readiness to change, right? So it's still about getting that healthful dietary pattern in, but low calorie, and can create an energy deficit for you for weight loss, okay? Now, when your patients are coming to see you for the first time, you want to talk about diet, don't go cold turkey lah, straight away, oats only, no more this, and then, cut everything out. It's not going to work. So it's about, not about restriction. So dietitians and nutritionists are not food police. We are here to help you make healthier choices, right? So how do you do that? Simple. So depends on the readiness to change. If I have patients who are very gung-ho, forget that roti canai, I'll go straight for oats. Well done. You can keep it up, go ahead. If not, maybe still go for, switch it from teh-o instead of teh tarik to teh-o kosong now, right? Still have your dal. Maybe from roti canai, try to have chapatis or idlis, right? To reduce that calorie. If not, go for your toast bread with soft-boiled eggs. So do what is still within that mamak stall, but healthier choices, okay? Similarly, with your lunch, your dinner, go quarter, half. Do the suku separuh and switch off all the sugary drinks into just kosong or plain water, right? So these are just simple things to do. If I love all my Oreos and my, not so healthy snack, switch it. Take a fruit instead. Take some wholemeal crackers instead. Have a handful of nuts instead. So these are simple things that we can actually recommend to our patients. Now, at the end of the day, sustaining that is the most important. Now, why is diet so challenging? Actually, there are only three things for you to consider for your patients. Is it lack of knowledge? But again, knowledge itself may not be enough, as what Dr. Tan has said, right? Is it also lack of skill? Don't know what to do. So I know I'm supposed to eat healthier, but when I walk into a mama store, I don't know what to order, right? And at the end of the day, lack of commitment. What kind of support am I getting as well in my environment? So that's why diet is so challenging. But actually, when they follow it, the diet doesn't fail. Lifestyle does not fail. Okay, it's about our commitment and the behavior of our patients. Now, this is what we shouldn't do. Take away control from our patients, telling them what we think they should eat. All right, we can guide them. Okay, give them choices, but don't tell them what to do. And the other thing is misjudge the patient's sense of importance of behavior change and their confidence. You'll be surprised. Sometimes we think they can't do it, but actually they can. So let them make their choices. And don't overestimate their readiness to change also, both ways, right? So they may not be ready to start. So talk to them about, okay, so what are you ready to do? So maybe they say, okay, most of my patients will say, okay, I'll stop all the sweet drinks. Easy to do. I'll go on plain water now. Good. Let's do that, right? And then let's meet again to see, okay, what's your next step then that you want to do, right? And last of all, of course, judgmental, blah, 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 all those you have heard from Dr. Tan. And the most one is don't use scare tactics. I think nowadays I see that with education, all of us are more aware, we are more patient-centered. We don't do that anymore. If you don't change your diet, you're going to die, right? And I have patients who do tell me that I met someone, a healthcare professional, who tells me, if I don't change this, in 5 years' time, I'm dead. Well, if that works, but it shouldn't be all the time like that. Okay. So now the one thing about pre-diabetes is it's about intensive change though. So that's something we have to realize as healthcare professionals. It's not just a matter of switch this, switch that, and then you'll be all right. It's not. Okay. It's intensive change that encompasses medical nutrition therapy, physical activity, mental well-being, and getting enough sleep, right? Focusing and changing what is important to you now. Is it about earning that business thousands of ringgit, or is it about being around for the next 10 years to enjoy it, right? So those kind of conversation needs to take place. The last thing, the thing that will not work is tomorrow lah, I start my diet, okay? Or I just got an advice and then I walk out of the clinic and that's it. There's no follow-up. That's not going to work either, right? So I think that's the one thing we learned from all the DPP trials. So this regular follow-up in all the trials, monthly individual session, group sessions, lasting about 90 minutes even. Where got time? Where got money to do this, right? But the beauty of it today is technology, right? So it's time that we use technology. And in Malaysia, I'm happy to see that there's lots of technology company available now where we can actually get, and there are free apps as well, that you can actually use technology to let the patient self-monitor, right? And help the patients to stay committed. I think we have no choice but to move to technology. Now, one thing in the ADA guidelines said that it's the multi-component intervention packages that work, okay, where there's sustained behavioral changes. So we did this in IMU, if I'm allowed to just share that a little bit. So we work with technology, that's an Naluri app coming in, and we did workplace wellness, right? If every workplace could do something like this, and I know hospitals are doing it already, obesity programs and so on, healthy lifestyle programs. Actually, the ADA guideline says this is what works, right? You teach them what are the things like healthy cooking, healthy shopping, choosing the right meal, portioning your food. So this here you see all our staff learning how to portion foods. So does it work? So we did that for 2 cohorts and we published this recently. It worked. More than 5 kilograms weight loss, 6% from baseline, 1.2 units down in terms of BMI, blood pressure came down, some of their metabolic controls like HDL cholesterol went up, triglyceride came down, weight loss came down. Now, we didn't have enough people with pre-diabetes there, but we're now doing this again this year with higher risk patients. Hopefully, we can show you better data. But it's about that group, that sustained multi-component package that worked. So key takeaways now. Number 1, we know pre-diabetes is related to adiposity and insulin resistance. We must focus on weight loss. If the patient fits that BMI above 23 and they have pre-diabetes, so you aim at 7 to 10%, you're looking at 6 months. We have to create that calorie deficit, both with diet as well as exercise, right? The food choices matter. We have to get our patients, especially Malaysian patients, because we eat a lot of refined carbs, get the amount down, the type of carbohydrate food, switching it to lower GI, more fiber, more whole grains, right? And most importantly, avoiding anything that's sweetened. Don't forget the bigger picture. Promote healthful eating pattern. This is something all of us should be doing. We should be having more whole grains. Half of our grains should be whole grains. There should be fruits at least twice a day, 2 servings. Vegetables, at least 1.5 to 2 cups a day. Beans, legumes, nuts. So these are things that sometimes is not so, we don't see that so often in Malaysian diet, but it's time to promote this. These are healthy protein sources and low GI sources and cheap sources that is actually complete that we can add into the diet. Focus on lean proteins. People who eat fish most days of the week actually have lower cardiovascular risk as well. So I know some fish can be very expensive, but there are cheap ones. At least lean chicken, right? Stay away from your red meats. Those things still work. Healthy oils, yeah, use blended oils. That's what I tell my patients, right? So we need more pufa into our diet. We don't have enough of that, but we can have, oily fish, ikan patin, things like that. Beans and legumes also add pufas to our diet. And of course, focusing on lower sodium. And if we really want to help our patients, if you can initiate multi-component intervention program, workplace wellness, I think those are the things can help us sustain that lifestyle change and reduce the rate of pre-diabetes in the country. Yep, I think that's it, Prof. Chan. I'm finished.
Thank you very much, Prof. Winnie. Before I let you go, we've got 2 minutes.
Okay.
This is Ramadan month,
Mhm.
and so I think it is appropriate for you to perhaps just give a little bit of tips how you would recommend that patient break their fast, what kind of options, like what you just mentioned, and things about the GI. Does it matter if you start with protein and continue with carbohydrate, but still eat a bunch, still take a mountain?
Of course not. Yeah, no mountains here. Yeah. So I know I'm not Muslim, but I do have Muslim patients, and I think what's important when you break fast is you don't have to go. Well, first of all, your sahur in the morning, right? When they eat, go by the quarter half, right? That's the best. So go with your rice, your greens, and your proteins. It could be last night's leftover dinner. That's okay, right? And then have have your drink, preferably something that is maybe tea or coffee but without sugar. Then you go on your fast, and when you break fast, go with the korma. I think I understand that this is what is actually recommended as well in the scriptures, right? 3 korma to break fast, and then after that have your water, and go for your main meal, right? And again, be mindful. Okay, be mindful. But I'm not saying, oh, then I cannot enjoy all the Ramadan food that we have, Occasionally, you want to enjoy it, fine, but not all the time, not every day, right? So maybe it's a once a week treat. But most days of the week, you're eating a normal, healthy meal of quarter half, right? And that meal sequence that we talked about, Prof. Chan, start with your vegetables and your protein, right? And then only come to your rice. Okay, there seems to be a 20% reduction in blood sugar with that. But if I eat it all together, but it's a mixed meal, that's still not too bad,
Yeah,
right? But if it's just
absolutely.
pure carbohydrates, like a big bunch of nasi goreng, very little fiber in it, then you know that's not going to be good. It's going to be high calorie, and it's not good for your blood sugars as well, right? So still practice that healthy eating. And then after Tarawih, usually they will have a small snack, right? Just keep the portion low, right? If you don't have much choices, then keep the portion low, and then focus on the spiritual side of fasting. That's what I tell most of my patients. You don't have to go on a feast, right? Now the other thing is non-Muslims who's also going on a feast on Ramadan.
Break my fast
Yes,
3
that's
times.
right, 3 times. And then it's a treat for us to have so much food there. Make it an occasion, make it a once in a while thing to do, not an everyday thing to do. Right? So that would be something I think.
Thank
I
you
hope it's
so much,
practical.
Winnie. I'm sure there are more questions coming through. Please send them. We'll try and answer as many as we can after the last speaker. So thank you very much, Winnie, for that very practical session. We will continue with more questions for you. In the meantime, let me introduce Dr. Navin Loganathan, who is a diabetes care clinical pharmacist, very important person. He is in charge of the pharmacy services in Putrajaya Hospital Endocrine Institute. And I think Endocrine Institute has been recently opened. Congratulations, Navin. And so he's a clinical pharmacist, and he will take us through the pharmacologic treatment to manage prediabetes, because we've talked about the most important, lifestyle and diet, but some patients will need drugs to help them. So Navin, please address that topic. Thank you very much.
Thank you, Prof. Chan. So it's a pleasure to be speaking to all the healthcare professionals regarding prediabetes. And yes, we have heard about lifestyle from Dr. Tan. We have listened about diet from Prof. Winnie. So let's go to drug. But before I start, I would like to ask you all 2 questions. So when do you actually position drug in prediabetes management? So only when everything has failed? Or, do you put it earlier, before lifestyle, or after lifestyle failed, the diet failed? Okay, these are the questions that you might have in mind, right? And the other one is, are there any better than each other? That means whether the lifestyle is better than drug, or whether drug is better than lifestyle. So I hope we can address these questions throughout the lecture, right? So today I'll be talking to you about pre-diabetes management algorithm, and then I'll be sharing with you about some studies that's been conducted on pre-diabetes. Of course, that's not many, but we do have, yeah, like the DPP Chinese Prevention Study, Indian Diabetes Prevention Study, and so on. And also, finally, I'll be telling you what is the management of pre-diabetes in Malaysia like from the expert consensus and the key take-home messages, right? Sorry. No. All right. So we'll start off with this pre-diabetes algorithm. So of course, this is actually not a local algorithm. It's from America, American Association of Clinical Endocrinology algorithm, but at least they have outlined what are the treatments or how do you manage pre-diabetes. Of course, first on top, you see the yellow box is actually lifestyle. Very important. The emphasis has been given by our earlier two speakers. But later on, if let's say lifestyle has failed, you actually can go and use drugs in the management. Here you have the drugs that are outlined for it. Okay, of course you have low-risk medications like metformin and acarbose, and also some other drugs that you can use like the thiazolidine category and also GLP-1 receptor agonists, which you must use with caution. But let's look at the evidence after this, right? But before we go to the individual drugs, let's look at what we have in terms of the management strategies for pre-diabetes, right? So we have some diabetes medications like antihyperglycemic agents that are useful in delaying diabetes in pre-diabetes patients. If you start with metformin, metformin is a very old drug. Yeah, metformin was invented in the 1950s, so it's about like 70 years now. So metformin in studies of follow-up of almost 3 years has shown to reduce the incidence of diabetes by 31%, yeah. And also we have acarbose. Acarbose, almost similar, about 3 years study, have shown a reduction of 25% in delaying the diabetes incidence. And of course, we also had the thiazolidine group like pioglitazone and rosiglitazone with a higher reduction in type 2 diabetes, which is about 72% and 60% each. And we can't actually disregard the weight loss interventions, very important, because usually our patients, the Asian patients, are very overweight and obese. These are the ones that actually lead them to actually have the impaired glucose tolerance or diabetes eventually because of the high insulin resistance. So weight loss really helped. I think you've listened from the previous two speakers. So we have these two drugs and also like Orlistat, phentermine that actually give reduction. And finally, please take note that bariatric surgery is very, very effective. Finally, you know, I'm not going to talk about surgery here, I'm talking about drugs, but you bear in mind that it can reduce diabetes about 75%. Okay, reduction when you actually go for bariatric surgery. Let's go into some of the pharmacological management of pre-diabetes. So these are some of the early studies. DPP, Diabetes Prevention Program, has been, time and again, I think from the last webinar and even now, the speakers have been looking at it because it is actually a study on pre-diabetes. So in this diabetes prevention program conducted in 27 sites in the US, so you actually have 3 groups, okay? You have the lifestyle group, you have the metformin group, you have the placebo group, okay? Metformin probably because it's, an old drug, so it's been tested much earlier in pre-diabetes. So you look at the results here. So you can see that the lifestyle group actually showed a much better risk reduction of diabetes than metformin, okay? So look at that point, right? Initial stage, I think you can see here in the first 1, 2, or 3 years, you can see the curves actually really going towards lifestyle, okay? And then metformin followed by placebo. Metformin could reduce the risk of diabetes by 31% as opposed to 58% with lifestyle, right? let's look at this timeline here, because DPP study, Diabetes Prevention Program, is related with DPP-OS study. They are actually the same study, but same cohort of patients who were actually enrolled, but they were followed up for a longer period. Okay, initially about 88% of the patients from the DPP study were enrolled in the DPP-OS, and I think finally they had about 2/3 of them still remaining when the results were analyzed. So here, the DPP study actually began in 1996, and then the study was completed, the enrollment completed in 1999, and the results came out in 2001. The paper was published in 2002. And from then onwards, 2002, for another 11 or 12 years, they actually conducted the DPP-OS study to see whether there's any legacy effect. We'll look at the results after this. So, what is the main crust or the gist of this DPP and DPP-OS program? Of course, number one is lifestyle goal. They never said that when you actually start the drug, you stop the lifestyle. This is an important point. Even any CPGs, okay, still even a diabetes CPG or pre-diabetes will still have lifestyle as one of the goal on top of the drug. So lifestyle, they targeted 7% weight loss with about 150 minutes of activity every week, okay? And then on top of that, the group that had metformin, the metformin group, they started a metformin at a dose of 850 BD. All right, twice daily dosing. That gives you about 1,700 milligram of metformin per day. Right? Let's see what happens. So in this DPP-OS study, which is a longer period, as I mentioned to you, the whole study follow-up is 15 years now. It's published in the Lancet. So you can see in the placebo group, placebo, metformin, and lifestyle, all of them had the lifestyle prevention classes, right? So they go for classes. What did they do in the classes? They teach them how to actually have healthy diet, choosing their meals, and also going for exercises and everything. All the groups actually had 4 times a year. When you go to the metformin group, on top of that lifestyle classes, they had metformin 850 milligram BD throughout, and also in the lifestyle group, okay, they never had drug, but they had another intensive lifestyle class. They call it as boost lifestyle classes, which means that they actually had personalized coaching on the lifestyle for each patient, 2 times a year to actually, reinforce all the lifestyle interventions, okay? So let's look at what came out. In the first 1 or 2 years or 3 years, you already see the blue line, which is actually representing the lifestyle actually showed already as the separation, okay, showing remarkable reduction in terms of the diabetes prevalence, okay, diabetes incidence, right? And also followed by metformin. Metformin is the next, okay, that showed a reduction in diabetes, and placebo did not show much reduction. So here, the take-home message is that in the earlier stage, you can see very clearly that lifestyle really works. Lifestyle works in the first 2 or 3 years to really actually reduce the incidence of diabetes. Now, when you put the DPP and DPP-OS together side by side, you can see here DPP had about 3,000 over participants, and then DPP-OS had about 2,000 finally, okay, from that cohort. You can see that the effect was still there, but here the yellow bar, metformin, you can see has become much better in terms of delaying diabetes. So in a longer run, you can see that metformin given a longer period works, because you see in this DPP-OS study, the metformin was unmasked already because the trial is already completed. The patients, they just continued on with the metformin until they completed the DPP-OS study, right? So you can see here that in the longer run, metformin works. And what else that we can see in this study, this 2 DPP and DPP-OS, okay, where in the 10 years follow-up, you can see that the lifestyle group actually showed an initial significant reduction in weight. All right, you see the blue point here, blue line here. Okay, initial weight reduction was very, very great with lifestyle. So now we actually, we have listened to the experts talking about lifestyle, Malaysians, lah, just give me a pill that can just do the job, lah. I don't want to do the, I don't want to work hard. But just, you'll be amazed. I'm talking to HCPs, lifestyle really had showed the separation despite metformin being on board. And later the lifestyle catch up with metformin, okay, but they both actually gave the weight loss, and weight loss with metformin was about 64% in the beneficial effect, that's actually delayed the diabetes, right? So let's just go a little bit on the subgroup, okay? So metformin, in what kind of patients is it effective, okay? So in DPP, metformin was more effective in the patients who were more obese, okay? The ones who had higher BMI of more than 35, and also those who were younger, slightly younger, 22 to, in the 40s, okay? 25 to 44 years old. And then it didn't really show much reduction, in diabetes incidence in those who were lower BMI and also those who were older. Just, the opposite, right? It's just a message. So from here, what we can see here is that the incidence of diabetes was reduced, okay, much better with lifestyle, because the lifestyle group actually had only 42% reduction in, only had 42% of diabetes incidence, which is a 34% reduction in risk, and lifestyle can delay diabetes by 4 years, whereas metformin can delay diabetes by only 2 years. So later, eventually after 2 years, you will get diabetes from this study, from DPPOS. We look at other studies also. Okay, and metformin, the reduction is half only of lifestyle, which is about 18%. Now, we have looked at all these US studies, Caucasian populations. Let's come to our Asia. Our diabetes, I think we are different, right? I think in the sense that, of our genetic makeup and our lifestyle, Asians are different. So this is actually one study very early itself. I think this is in 2001. Okay, 2001, they published this paper, Chinese prevention study, and then they also did a study with a 3 years follow-up. So they actually had a placebo group, they had a metformin group, they had an acarbose group, and then they had a lifestyle group, lifestyle and healthy diet. So if you look at metformin here, metformin actually reduced the incidence of diabetes by 65%. And bear in mind that they actually used a smaller dose of metformin of 250 TDS, in this study. And it managed to actually, all these patients are actually IGT, in fact, glucose tolerance at start, and then remarkable reduction with just metformin 250 TDS alone. Now, China is a big country. Now another country, another giant, I think, with a high diabetes prevalence is actually India, right? So let's look at the Indian Diabetes Prevention Program. So this Indian Diabetes Prevention Program, they also recruited patients with IGT. What they actually what they did was, they also had this lifestyle arm, lifestyle modification arm, they had metformin arm, and then they had the combination arm, lifestyle and metformin. So lifestyle, what they did was, in those patients who they recruited who are already cycling and doing very intensive labor, like, working in the, sawapadi or whatever, right? So actually they just maintain them. If they actually did the physical labor more than 30 minutes, okay, just maintain them. They only taught the patients to exercise, those who actually never did exercise, so they asked them to do brisk walking, and then they actually asked them to do it at least 30 minutes per day. All right, and then they went on, and the cohort of these patients, right, they are not very high BMI. The BMI is just 25. The median BMI is just 25. But then they're actually younger patients. This Indian prevention program, the patients were actually in the 40s. Median age was 45 only. But they were mostly having central obesity. Their insulin resistance is very high. HOMA-IR is about 5.0. So very insulin resistance, central obesity, and all that. Waist circumference is very high. In this outcome of this study, you can see that actually metformin, lifestyle, either lifestyle and metformin, they are all the same, managed to reduce. And the slight difference between the Chinese prevention study is that they use a metformin of 500 BD. Okay, they used a metformin of 500 BD. They did attempt to actually increase it to 1 gram for about 40 days, but then they actually had to revert back because a lot of patients started having the hypo symptoms. So they went back to 500 BD. All right, but the take-home message here is that you can see that either lifestyle or metformin or combination all manage to reduce the incidence of diabetes as opposed to control. Let's go to another study. This is not metformin, so you have another drug, which is the alpha-glucosidase inhibitor, which is acarbose. So this is stop-Needham trial, which is also in the early 2000s. So these patients were all patients who had impaired glucose tolerance, and then they were enrolled, they were put into the acarbose arm and also the placebo arm. The patients who went to the acarbose arm actually had a significant reduction of, diabetes in the sense that actually it reversed the impact glucose tolerance to normal glucose tolerance after the 3 years study period. Okay. So we also have other classes like the thiazolidinediones. You have the DREAM trial, which was much earlier on in the mid 2000, of course, with rosiglitazone showing similar pattern, similar findings of delaying diabetes, and also you had the ACT NOW study, which used pioglitazone, also showed that actually the incidence of diabetes is delayed, much reduced, and also some of them have showed that they can delay complications as well. Right? But we must understand that at the moment, okay, they are not really very favored. In fact, in the AAC algorithm, I showed that they put their use with caution because of this black box warning with thiazolidinedione group that actually can cause or exacerbate actually the congestive heart failure. It also has some other risk of bone fractures, weight gain, bladder cancer with pioglitazone, and also increased LDL with rosiglitazone. So we are coming to the newer classes, okay, now in this era where you have the GLP-1 receptor agonists, which are very hot now. I know that many people, many of you watching now actually have heard about it, but let's look at the evidence that we have for prediabetes. So this is one of the earliest GLP-1, which is exenatide. Okay, the started exenatide in patients who are this is very obese, almost 40, BMI is almost 40, and then the 25% of the patients in this group already had impaired fasting glucose or impaired glucose tolerance. Okay, so what happened to them at the end of the follow-up period? So those with exenatide actually managed, I think a higher percentage of them, about 77% managed to reverse the impaired glucose tolerance to the normal glucose tolerance. Very high number, as opposed to only 56% with placebo. Okay, that's with exenatide, and I'm sure you all have heard about liraglutide as well. They have also done this scale study for obese patients with prediabetes. Okay, so of course you can't separate weight when you're talking about prediabetes because it works like that, you see. You have your obese and then your overweight, and then that causes insulin resistance, and then you start to have prediabetes. Okay, so weight change, weight goals are very important. So in this scale study, you can see that those who were started with this liraglutide had, the orange bar, had a significantly higher weight loss, about 8 kilos compared to about almost 3 kilos with placebo. And of course, in these patients, you can see on the right-hand side, those who were actually nomoglycemia at screening actually, those who actually were started on liraglutide had more of them, remaining nomoglycemia and did not develop prediabetes as opposed to placebo. So we are coming here, the two questions that I asked you just now. So when do we use drug? Whether everything as sulfate, how long do you want to wait? Do you want to just keep on going with lifestyle modification for years, and then when you start drug or you start concurrently? I hope you are enlightened a little bit now. So let's go to the Malaysian consensus. So we have this paper by Prof. Mafauzi and all in 2020 has outlined what is Malaysian experts' opinion on the management of prediabetes. So you can see that in patients who already have a history of cardiovascular disease, who already have a history of gestational diabetes mellitus, patients with high BMI, overweight and obese with, A1C in the pre-diabetics range, you have to start the lifestyle modification. We are convinced now because even the drug trials have shown that the lifestyle modification works, at least at the beginning part. It is very effective in lowering weight, in reversing impact glucose tolerance. What do you do next? How long do you keep the patients, the people, pre-diabetes patients on lifestyle? Okay, no, you can wait for about 3 to 6 months. This consensus says that, you wait for 6 months. If it doesn't work, look at the fasting plasma glucose. If it's more than 6, FPG more than 6, or the A1C moving towards the pre-diabetic range, more than 5.7%, then you start metformin. Do not wait. Start metformin. Of course, you have to start low. Okay. Evidence, you have seen evidence, 250 TDS, it works, 500 BD, it works at start. So with evidence, we are actually suggesting that you start low with 500 mg, BD dosing, and maybe you titrate upwards slowly up to 1 gram BD. And of course, as what usually pharmacies say, the patients initially, they will start to struggle with some of the GI symptoms that will go on for about 2 or 3 weeks. They'll start to say that I'm having, it's very crampy, I'm having flatulence, I'm vomiting, I'm having diarrhea, and that's not a reason to stop. So what we usually tell the patients is that this will go away with your time as the metformin adapts to your body. So do not actually, that is not a reason for stopping metformin. So we have come to the last slide of mine, which is the take-home messages. What I would like to stress here is that from the evidence presented, lifestyle modification is very important. You have to have lifestyle modification even though you have drug on it, and evidence shows that lifestyle modification shows good initial body weight reduction and delay in the incidence of diabetes, as shown by the DPP study. Metformin showed better reduction in diabetes incidence as compared to lifestyle in the long run, in the long term, as proven by the DPPOS study, the Chinese prevention study, and the Indian diabetes prevention study. Okay, so how do you go about it? The Malaysian experts recommend that you add metformin in pre-diabetes patients when the fasting plasma glucose is more than 6.1. Okay, there was actually an error typo in the earlier slide, 6.1, sorry. And then lifestyle modification fails after 3 to 6 months, you can already start metformin. With that, I pass back to the chairperson. Thank you.
Thank you so much, Dr. Naveen, for taking us through the pharmacological options that we can depend on to try and get our patients to prevent them and delay their progression to diabetes. While we are waiting for our other faculty to get together, we will try and address the questions. I think perhaps I'd like to, get Naveen, since you're here already. The question that came was, what dose of metformin do you use? Should we go straight to 1 gram twice a day? So I think you did mention it.
Yeah.
Please re-emphasize that.
Yeah, I think this is very important. You are starting metformin in people who are metformin naive. They have not been introduced to the drug. So you have to start slowly. That's why just now we recommend 500. Some people, you can actually start, I think gone are the ages that we start with 250, go to 500. Some people from 500, they go to 750 BD and then go to 1 gram. So you have to titrate slowly. But I think the consensus state that you can actually start with 500. And then monitor your patients, very important. If they can tolerate, within a week or so, you can already step up, depending, of course, also depending on the outcomes. Yeah. So the starting dose, you can start with 500. No problem. For in centers that I think have 850, they use 850 as well. Like, of course, I will talk from the KKM part. I think in University Hospital or somewhere that if you have 850, you can also use 850 for a start. Then after that, you go up, titrate upwards. Yeah.
So the answer to that question is start low and go slow. As your patient tolerates it, start with after dinner 500 milligrams and then slowly go up depending on the patient's tolerance. But perhaps, Naveen, while you are talking about metformin, if they do have problems with the regular metformin, is there an extended release that may be helpful for some patients?
Yes, yes. I think now we have, extended release formulation that's very helpful. Number one, in terms of compliance, and also number two, in terms of the GI side effects as well. So you can actually take the metformin XR, which is, it can be taken during the evening meals. Okay. So why the reason we say actually you take during evening meals is actually because it works by actually reducing the hepatic glucose output. So it targets the nighttime production of glucose. So you take it with the evening meals. So this XR metformin is very useful because it's also OD dosing. So you can take just once a day. All right. So I think it will minimize the hassle of taking twice daily dosing.
Thank you very much. Let's start with Dr. Tan. I'm going to do away with the doctor lah, huh?
Yeah.
Sorry about that. Let's make it easy, informal. You know, we are so excited. There are more than 2,000 of you who have joined us. We are really, really hoping that you will gain from this session. And this is the most important, the Q&A. Look, Ming Yong, I'm told, what kind of exercise would you recommend? If they cannot do the aerobic exercise, will resistance exercise alone do? And what do you recommend if a patient has osteoarthritis, which is common, and they say, how to walk? Okay, Ming Yong.
Thank you, Prof. Chan, for the question. I must confess I'm not an exercise expert, but I try to learn it myself. For patients, especially those who are overweight and obese and the elderly, yes, it's very common. They can't walk. But whatever they can do, even 10 minutes. Some of them, if they have osteoarthritis, if they can walk 10 minutes, they can break that up into 3 times a day. For the elderly, they are not mobile. So sometimes they can also do chair exercise. There are chair exercise for aerobic. If you go and search the Googles, YouTube, yes, you will find them. And there are resistant exercise. All this will help with the patient that there is sedentary all the time. Very important, start moving. Moving in some form. Chair exercise, short exercise, 10 minutes, 3 times a day. All this will help.
Right. Okay, I'm going to sort of like rotate the questions here. Winnie, how do you combat sugar craving? The supermarket is full of sugar things on the shelves, and you can get buffets that are full of sugar.
Yep.
So Winnie, how do you get them to restrict their diet maybe? How do you teach them to choose correctly?
Yep. Okay. Yes, there are. Sugar is everywhere, as we've discussed it earlier. I think it's more on the mental, right, and not so much on the physical of actually doing it. So for a lot of patients who are not ready to give up their sugars, we actually do need to discuss with them what are they compensating for. So most of the time, we are compensating for stress. We are compensating for that sugar rush that makes you feel good. So is there anything else we can actually swap to that gives you that same good feeling, right? Exercise is one, again. But secondly is actually certain dairy products like cheese give you that same good feeling. Proteins give you that same good feeling. Nuts also can give you that same good feeling. So what I normally would discuss with the patient is why are you craving for that sugar? So we have to understand the underlying reasons for it. And if they are actually looking at stress relief, then let's look at swapping it to something else, right? So I think sometimes that can work, right? So, but there will always be the ones who still need to crave certain sweetness. Then maybe can we look at switching from, more of the non-nutritious sweeteners option? So that could be one thing, right? Reducing the frequency could be another. So if I always take it every day, I now go to maybe 2 times a week, and then later I actually start swapping, replacing it 50% with water now, and then suddenly I don't have it anymore. So it's a process that we need to do. It's interesting that you notice all the sweet stuff. It's right at the checkout counter of the supermarket, because then you go, oh, I think that looks interesting, and I put it on again. So that is actually a marketing tool.
Absolutely.
And there are studies that show what if we swap that over, and then people don't take it anymore. Just something interesting that I observe. But yeah, we have to work on what is the underlying factor that makes people crave for that sugar. And most of the time is that feel-good feeling,
Yeah.
that comfort food kind of thing. So we
So
have to find the replacement.
I think a lot
for
of
it.
problems are that the patients not patients, individuals, that includes us as well.
Yeah.
What do you do when you're stressed? What is
Yes.
your stress reliever?
Correct.
And if stress reliever is to put something in your mouth, that's the problem, isn't
That's
it?
right, that's right.
Okay.
So I've tried, well, why don't you try chewing gum? You know, taking
Right.
chewing gum, you're still chewing,
Okay.
gives you that
Feeling.
sensation, right? And then rather than just popping like a huge cake into your
Yeah,
mouth.
yeah.
So tricks and tips like that may work for some people.
Right. And to be honest, let's just again get our priorities in the sense that these individuals are pre-diabetic. They are not diabetic. So basically, the sugar is not really taboo, is it, Winnie?
Depends on how you look at
Yeah,
it.
I mean taboo in the sense that I think again your comment on quality and quantity.
Yes, that's right. So part and parcel. I mean, the recommendation is not more than 10% of your total energy intake. You calculate that, that's quite a lot of sugar actually, right?
Yeah,
so yes, it's not exactly entirely taboo, so switch where we can. Switch and change it where we can.
Again, I
Yeah.
think to try and reduce their sort of like what we call it sugar, wanting to have that
Yes,
sugary
that's right.
taste.
That's right.
Right.
Yeah.
Okay, Naveen, there's a lot of interest in using metformin. What is the time to initiate it? Again, guidance to choose which medication, and again, when would you choose metformin and metformin XR?
Okay. Of course, we just now it's very clear that when the fasting you have to start lifestyle modification first, lifestyle intervention. Then if you see for 3 or 6 months, then the consensus says that you can already start metformin. Okay, if the fasting plasma glucose is more than 6.1 and the A1C is more than 5.7%. Okay, but in the setting that you have an XR formulation, you can already use it because it's very convenient for the patient. It's just an OD dosing. You just dose it with the evening meals, and then it has less GI discomfort. But of course, you can also use the normal metformin if the patient can tolerate it. It's just about tolerance. And our patients actually, they go on with metformin for many years. After they've adapted, they can be on metformin for many years without any problem. Okay, so what I mean is just the first month, the 2 or 3 weeks, you have to see whether they tolerate the formulations. Yes, I agree that even the immediate release formulations of metformin in the market, there are many formulations, many brands. So if they might not tolerate some metformin brands because of the excipients, and not really due to the metformin active ingredient itself. It's how they formulate the tablet. The other things that they put in the excipients may not be as friendly. So of course, these are also some considerations. But if they can tolerate a particular brand, then just go ahead. What we want is just a metformin. Yeah?
Absolutely.
Yeah.
Yeah. Ming Yong.
Yes.
Right. You've been asked about what happens to people who work on shift. How do you try and work exercise or physical activity around shift work? When they say, "Ayo, I'm working through the night. I don't even have enough time for sleep." Ming Yong.
This is a very practical question, Prof. Chan. And we have a lot of people in Malaysia who go and shift work, not only in healthcare, but in the industry, in the factory. It is still possible. The only thing we need to talk to the patient, because when you work on shift, you're only doing usually 8-hour shift. So there are other times. It is the patient, we have to motivate them, they have to believe that, very important, I would like to stress that, they have to believe that lifestyle intervention will help them. If they have this positive belief, then we can negotiate with them. Because you're not working 8-hour shift, you're not working 24-hour shift a day. The longest shift they do, like nurses, some of the nurses, is 12-hour shift. So maybe during the shift work, they are working, and there is a break of maybe an hour. So during the break of an hour, they already can do some walking, something that they can find time to just 10 minutes, as the 10 minutes is very important. You don't have to do 30 minutes at one stretch. Study has shown that 10 minutes, you break the 30 minutes into 10 minutes, it works. It produces the same result. So before shift, after shift, and when they can go on night shift, when they get up, before they go to work, they can do 10 minutes.
Absolutely.
And when they come back, before they sleep, they can do another 10 minutes. In their work, they can do another 10 minutes. It is possible. But the most important thing, you got to convince them. Lifestyle helps them to improve their physical fitness.
And I think the key message there, Ming Yong, is that work it within the schedule, work it within
Yes.
their lifestyle, rather than ask them to find time to go to the gym. That will
Yeah.
not happen. But as
Yeah.
exactly what you say, if you can start doing part of the exercise prior and part of the exercise after, and then maybe don't call it exercise, just increase your physical activity.
Yes,
It's really a dirty word. And that brings me to Winnie. Winnie, you know, I like what I was told by Professor Amir, my mentor, who says diet is a 4-letter word. So the question from this very practical person is, in the canteen of the factory, okay, or even in the hospital, what is the best choice? Here are the choices that are available in their canteen.
Yep.
Nasi lemak, nasi goreng, mihun goreng, kueh, sandwich, roti sardine, plain porridge. What do you choose?
First, you change the canteen food.
Change the,
There is simply
Change the
no good
caterer.
choice there.
change the canteen.
Yeah.
Operator.
Yeah, operator. Yeah, that's what I mean, one of the, that becomes a real difficulty. So again, how often do you eat in that canteen? Minimize that.
Okay.
Bring food from home,
Yeah.
right? Eat your
Yeah.
breakfast at home,
Sure.
right? Then just have one meal there. And when you have no choice and you have to eat there, just cut the portion. Eat less of that, you know, and then bring some fruits along with you, and minimize the exposure to having to just choose there. If all 3 meals is there, then
Koyak.
that's koyak. That's very hard, right? And
So-
but there are things. I mean, we do have some patients who their choices are not so. So sometimes they use meal replacement instead, right?
Yeah,
If
yeah.
they can afford it, they will take meal replacement, so they minimize eating there and cut down their calorie intake.
That
Yeah.
brings me to the next question, which is really quite appropriate. Healthy food choices, Winnie, are expensive. You find that, now you're good. Okay, what is not an expensive healthy choice?
Menu ram is not expensive, right?
Alright.
I think the key thing here is that what do we mean by healthy food? If you're talking about quinoa, you're talking about brown
Yeah,
rice.
tell me.
Yeah, sure, it's expensive, right? Why is it expensive? Because there's no demand. Because Malaysians are not buying it. When we buy more of it, they will bring the price down because the sales is economics, right? It's about the sales and the demand. But at the same time, you don't need to eat all that sort of expensive food that's health food. What you need is your regular food, right? Even your mama stall, as I said, choose healthier choices. Don't go for those that's very high fat. Go for your normal half-boiled egg with your toast bread, right? Occasionally maybe some idlis or a chapati with the dal, and that's it. Then when you go for your, when we eat in our hawker stalls and all that, try to look for the mixed rice. I know mixed rice prices have gone up. My patients told me, hey, now mixed rice also very expensive, you know. Right? Yes, that's true, but it's still a healthier choice. Go for your quarter half wherever you can. If you have noodles, go for soup noodles rather than fried noodles. So it is still possible for you to make that choices, right?
Yeah.
And at home, cook more at home. Because when you buy and you cook at home, it's cheaper,
Yeah.
right? And it's good for the whole family as well. So Malaysians need to start thinking about cooking at home. During COVID, everyone in the initial stage, we all
Yes.
cooked at home. What happened to the patients?
All got
Fantastic
better.
blood sugar, all got better.
Yes.
Because they no longer eat out and they eat in. And they learn new recipes and all that. But now we're back to our old habits, you know. So that has actually proved itself that plan your meals. You know, for that week, plan your meals, cook it in bulk, freeze it, and then come home, just unfreeze it and eat it. So things like this can be done. It's just that it's not a habit for us. It's so easy because eating out is so cheap. inverted commas lah,
yeah.
as compared to overseas country, you know.
Correct.
So I think sometimes we have to be more aware and we need to plan our meals properly. So it is possible, and the excuse that, oh, healthy food is just expensive, so I can't have it. But again, what do you mean by healthy food? The definition of it, right?
Correct. Correct. In fact, I think just to expand what you said, during the COVID and the MCO, right, everybody was saying, doctor, I couldn't go outside, not allowed to go and exercise.
Yeah.
How? But they all lost weight.
Yes.
Their sugars all
Correct.
got better.
Yes.
Dr. Tan, you know, it just throws exercise out the window. Where they say, oi, I didn't exercise and still my sugar got better. Why? Because the wife
Diet.
started cooking.
Yes. Healthy.
Exactly. Yeah. Yeah.
Right. Dr. Navin, your turn.
Yeah.
Right. The question that I like here is, how long do you give metformin for? Is there a do you get hypoglycemia when your patient is on metformin? I think that's a good question.
Yeah. Actually, hypoglycemia can happen when metformin is on board, but you must check what the patient is on. I mean, if you're talking about diabetes patients, if they are already on a concurrent sulfonylurea or insulin, then you can actually, they have a higher risk of hypo. But here in this pre-diabetes context, we are talking about just metformin without the other insulin secretagogues, okay? But I don't know, I've also read some of the papers, and the one that I quoted from in the Indian Diabetes Prevention Study is that I think when they were started metformin, all these people who are, you know, who had IGT, right? I think they could only tolerate it for 40 days because they had some symptoms of, you know, maybe they were symptomatic, okay? They had some symptoms that they could not tolerate metformin, like hypo symptoms as well as GI side effects, and then they were actually reversed back to 500 BD. So the thing is that we just go by tolerance, how much they can tolerate. Okay, the other thing is that how long you can give metformin is, in the study like DPP, DPPOS, actually they continued on, because the Stop Needham study have showed that actually in 3 years, the patient, 30% of them will still go and develop diabetes. You know, this treatment that you're starting, lifestyle or drug like metformin and all that, it's not to say that the whole cohort will just not develop diabetes. Some of them will go on to develop diabetes. It also depends on, you know, the overall their lifestyle, genetic and all that. So the thing here is that I think they just have to go for a twice yearly follow up and just keep on monitoring so that their A1C stays within the normal range. Okay, the goal here is to reverse diabetes. So I think you can give metformin for as long as, you know, you don't get diabetes lah. If you get diabetes, you still can put metformin on board as well, because that's another story. So I think we can continue metformin.
Absolutely. I think you should continue it for as long as the patient is willing to take it, because basically what you're doing is you're delaying progression.
Yes.
You have not cured the patient. And so the problem is, if the patient says, can I have a holiday from it, then you have to look at the individual problem to see whether or not they can. But again, with regards to the dose, the reason why the Indian Diabetes Prevention Program ended up with 500 twice a day is like what we ourselves clinically have found, that patients in Asia, many of them tend not to be able to tolerate it beyond 1 gram. So if you actually get to 1 gram, you're kind of like doing quite well already. If you can't move above 1 gram full dose daily, you'll still be able to, in the Indian study, in the Chinese study, show prevention of delay to progression, right? So, Dr. Tan, I like this question regarding a woman with gestational diabetes in the past, and now she is busy with do-re-mi at home, and what kind of physical activity would be appropriate? Is household chores considered exercise?
To answer your question, household chores is what we do every day. It's different. A physical activity, what you do every day, is different from exercise. Because physical activity, the intention is not to improve your physical health and improve your health. Whereas exercise is intentionally planned. It's planned, it's structured, it's repetitive. So there is a difference. and you need to reach the moderate intensity in order for your body to improve the physiological health, such as reduce your blood pressure, your blood sugar, and increase your insulin reduce your insulin resistance. So if you have do-re-mi, depending on their age, get the children to wherever they are and let them free, because you have to look after your children. You go after them. Remember the burst exercise, activity 3 times a week. That is what we do as parents. If you can't, get them in the house. You can have great games. Get them run about. Children will never sit down. So if let's say they are a toddler, you got to go after them to make sure they are safe. That will be, it's you have to create the opportunity, think about it, and you helps to
Tire them out.
help them out. At the same time, you help yourself.
Right.
So it is possible. It's just that very important, believe that exercise is going to help. It's different. Daily physical activity and exercise are different.
So built in, again, in your
Physical
physical,
activity.
in your day-to-day work, something pleasurable, something that you can continue. Thank you so much, Dr. Tan. We need tons of questions for you as usual. Give us an example of low GI fruits. Low
Fruits?
GI fruits.
Oh, okay. Now, the GI of fruits varies depending on the ripeness of the fruit and the fiber content. So things like guava, apple, which are not so watery, right? Watermelon's GI, sometimes it's low, sometimes it's high, it depends. So go by what your patient tells you. But if they go for more high fibrous fruits, that should be generally okay. But the first thing is first, get the patient to eat fruits.
Yeah.
That's first, right? Then you can recommend, because a lot of my patients don't even eat fruits. So even if they start eating a watermelon, good, right?
Okay.
Then if you find that the cost of, because in pre-diabetes, you don't really monitor blood sugars.
Yeah,
So it's just about
sugar.
getting in,
Absolutely.
5 servings, 6 servings of fruits and veggie. So that's about it. But if you have someone with diabetes and you find that the fruits actually raises blood sugar
Correct.
level, then you swap to a low GI option already.
Okay.
Yeah, but in pre-diabetes, I wouldn't, as long
I
as they
find-
eat some
I
fruits.
find a lot of my patients tend to go overboard and they take only fruits rather than a balanced meal.
Okay. So no, that's something that you want to, if they're using it as a snack, but if it's just a fruit lunch and then after that nothing.
Yeah.
But you see, a balanced meal is about the whole day as well, Prof.
Correct.
Right? What you take in the whole day. And then you also measure, if you can meet all your recommendation, not just through one meal, but throughout the day. Right? So if they have they have fruits for breakfast, right? Fruit juice, for example, that's very common. And then they have lunch and then they have dinner. But there is balanced meal there. I think that's fine. Again, we're talking about pre-diabetes. We're not talking about people with
sure.
diabetes. Yeah.
Absolutely. Yeah.
Yeah.
So we need to try and make sure that we are answering the question on a person not quite diabetic, but can become diabetic in the future.
Yeah.
Right.
So it's calories and again weight gain, focus on the bigger picture there.
I like this
Yeah.
question. And if the patient is very good, good with diet, good with activity, and then they're going to go on holiday to Penang for 1 week, especially when it's Hari
Penang's
Raya.
my hometown.
Can they break their fast and indulge for that 1 whole week?
Well, you see, to form a habit, it's 66 days apparently, right? So if they already formed that habit, and most of the time they are okay with it, I will say go ahead and enjoy yourself, because they are unlikely to go and let go completely already, okay? But if they are starting to actually try to eat healthy, they haven't quite get there yet, but they're on their process of doing it, then I would probably tell them to increase your physical activity while you're in Penang. Go to the beach, swim, walk more,
yes.
so you can burn off some of the calories in case you're
Absolutely.
eating a little more.
Yeah.
The minute you come back, you go back to your normal lifestyle again. Right? Don't let that overindulgence continue forever. Now, I'm from Penang. I overindulge in Penang as well when I go home. Right? I mean, like the best char kway teow, man.
Yeah.
You cannot just I must have that fix.
Yeah.
You have it once.
Yeah.
You don't have to have the fix every day.
Right.
Right? And then you walk a lot more anyways. So I think tracking it and monitoring then you still balance it. So I would weigh myself before I go back to Penang and come back and weigh myself again, just to make sure my weight stays the same at least, and it doesn't
Unlikely.
go up. Now, if it goes up, Chinese New Year, right? Then what do? You get back again to your routine and trying to bring it down again. It's catching the slips before it gets too big.
Absolutely.
Yeah.
I think the key is to allow them to have something, allow them to have what we call a cheat time, whether it is one day or one meal, and as long as you go back rather than stay
Correct,
cheating.
yeah. But
right?
you need to work with them to make sure that it's already a habit for them. Then that cheat day is okay. Right? But if it's not quite a habit, then you want to make them more mindful.
Okay, thank you so much. Dr. Navin, right, you started the patient on metformin. What do you monitor? How do you tell whether the patient is responding to it? Again, I mean, perhaps it's a very good clinical question.
Yeah, of course. The consensus says that actually you have to do a regular monitoring. You can do a yearly or I think bi-yearly monitoring of the fasting glucose. Okay, they can actually get it checked. I think you can go to the KK's Klinik Kesihatan, or even you can do your own check. Nowadays, I know many of them just go for the medical checkup in clinic, the Gribbles. You can just get the lab results out. You can actually do your own, and but of course, I think it's best to actually go to a doctor and then just continue to monitor. The other thing is that in terms of side effects, we are very cautious about that. This is mainly, I think, due to some brands and excipients, as I mentioned just now. So how frequent do they actually have this GI side effects? In the initial stage, there was struggle, but if you still notice that after 1, 2 or 3 months, they still have it, then I think you really have to also, consider actually tapering down the dose, or probably taking it off or trying something else. But most of the time, I mean, from our experience, is that it will adapt. Okay, it's just that the patients sometimes they get restless initially when they start to have the diarrhea or flatulence or GI side effects. But I think they need to be a little bit patient. I think it's also the role of the healthcare provider like us to actually convince them that it will settle, in a short period of time. So I think monitoring for metformin, mostly GI, I think it's not a hypoglycemic drug, so you don't have to really monitor so much for hypo and all that. It's generally safe, very old. In fact, I think it's the oldest, and together with metformin, they came out around the same time, 1950s, oldest, and actually still you can see metformin is there in all the algorithms of even diabetes and all that. It's an old, cheap, and very good drug, actually.
Yeah, I think there was a question earlier on about whether metformin can cause hypoglycemia. Although we know by the way it works, Navin, that actually it's not supposed to cause hypoglycemia. We do have patients coming and saying, I feel very hungry.
Yeah, hungry.
So you have to listen to your patient, I suppose, but I would really be very confident to reassure them that they will not get severe hypoglycemia where they might pengsan or things like that.
Yeah, correct.
Right?
So I think, Prof, to add on to that, I think I've seen a pre-diabetic patient also started on metformin, now already come to normoglycemia. But this patient, when she was already, the sugar's already at 4.8 or something, although it's still in normal range, she already start to have like, she feels different, and feel like she wants to eat and a little bit hungry and all that. So symptoms do happen, although in textbook we know that it says that it's not a hypoglycemic, it's just a euglycemic medication. But in practice, I think Prof Chan and the rest agree that you do encounter this. So don't just underestimate that. You still have to talk to your patient and see what you can do for them.
Ming Yong, your turn. All right. You did talk about this, about the exercise, 150 minutes per week. Do you need to space it out, or can I hantam one shot 150 minutes on Saturday because I have time on Saturday?
Thank you, Prof. Chan. Again, it's a very practical question. This is what a lot of my patients, especially those in the workforce, this is what they do. They say only weekend I can exercise. Which is true, 150 minutes. Why don't we do everything in one day and that's all? But they have to understand the effect of exercise on your physiological changes only lasts 48 hours. So if you do only, let's say, Saturday, Sunday, I finish 75 minutes, it lasts until Tuesday. And Wednesday, Thursday, Friday, there's no effect. That's why the recommendation is spread it out. So we got to negotiate with them. How about weekday? Can you put on something extra 1 or 2 days? Plan for it. And as we mentioned, exercise, you plan for it because the effect is on your physical fitness. Whereas you are busy every day, there is no, actually, it's unplanned, it will not improve your physical fitness. And after talking to a patient, as what earlier said, very important, listen to your patient. See what works for them. Don't tell them what to do, but discuss with them what is feasible for them. And all of us have 24 hours. It's how we plan our time. So if they understand the benefits of it, there is a possibility they can also plan their life to achieve the the positive outcome from it.
Right. I think, again, just to reply this question, life is not fair. Okay? You cannot hantam one shot. If you don't exercise for more than
2 days.
72 hours,
2 days,
actually
yeah.
for 2 to 3 days, what we call the aerobic base, the insulin sensitivity has been lost. So you can't do it. You can't just do all at one go hiking for 3 hours and then that's done for the week, right? Okay, I like this question, Winnie. Nephrology, they have patients too, and they have patients with some chronic renal impairment and pre-diabetes. And you tell them, take lots of beans, legumes, and nuts, and the nephro says, no, 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 no. How do you sort of balance the two?
Okay, it depends on what the stage of renal failure is. So if the stage of renal failure is early, then protein restriction is actually not necessary.
Yes.
Yeah, and
Yes.
plant proteins has been shown to actually delay renal progression. Yeah, so switching to more plant-based is fine. But if they're towards end stage, then it's a different story.
If like
the MNT
CKD3,
changes.
CKD3, they're supposed to
Three,
be
I think,
restricting protein.
Not yet, depends, yeah, not yet. So when we say restrict, because most Malaysians eat about 1 gram per day, so normal protein is about 0.8, right? So I would look into where the protein sources are coming from, and at stage 3, unless it's 3B onwards, but actually it's still not 0.8, which is normal protein. Only at stage 4, 5, we have to go 0.6 already.
Okay.
So that is a real reduction in
So
protein.
you think that most of our Malaysian diet is already pretty low in protein?
No, no, they're not low in protein. They're about one gram.
Pretty
high.
normal protein, not
Normal
really very high.
Yeah, unless
Yeah.
they're super high proteins. Yeah. So again, it has to be individualized.
Okay, so I'm kind of like running out of questions to ask you guys, man. Okay. Anything you want to
Sorry,
say?
just about the beans, legumes, and nuts. It's also about phosphate.
Yes.
Yeah, it's about phosphate as well. Then again, for phosphate, most of the time from processed food, that's where phosphate is most absorbed. So if they come from non-processed food, the phosphate absorption is actually lower. Yeah.
Okay.
So we need to individualize it.
Okay, I'm going to ask each of you to give some final statements to the listening public, healthcare professionals who have joined us during the Ramadan. Before that, I like this question for Dr. Tan Ming Yong. How do you try and engage the entire family, especially when you have problems of overweight and obesity in the children? Ming Yong?
I think that is again, a very practical question. If you have children, they are big. In fact, in Singapore, they have done the study. If you have children, they are big, you got to engage the family, the parents. Because children are not born to be big. It is usually the environment that get them even bigger. So it is important to get the parents first, especially because children may not understand why I need to lose weight, why I need to exercise. And children are naturally already active most time. So we got to engage the parents to come together to change the healthy lifestyle, to go for their weekend and spend quality family time in the form of some physical activity for the family. That I think is very important. The parents have to change first because the parents were influenced in terms of physical activity, in terms of the meal that they prepare for the children. So it is the whole lifestyle, not just a physical activity. And the quality of time is very important. It's a family time. This is what we emphasize for mental health.
Yeah, I was just going to ask you, you're talking about using all these gadgets to help you improve activity. I was just thinking, conversely, all these gadgets, they're just sitting in front of it and watching and not moving. Ming Yong?
But there are some programs. When
Oh,
I
there are
was in
very
US with my grandchildren, there's dancing, there's
Yeah.
playing tennis. There's a lot more.
Games.
Not just gaming. There are more than that.
Right. Yeah, thank you very much. We're going to go to doing the post-test questions, but before that, perhaps, what would you like to say to the some messages? Start with Dr. Tan.
Well, after my 35 years of working as a diabetes educator, this is what I noticed among my patients. Those people in their 70 and above who are healthy, straight away you know that they are regularly doing physical activity. You start now, you may not see the effect, but on long term, it really improves your physical fitness, your general health overall. So it's so important. Start now. If you have not started, start now yourself, or encourage your patient to start the lifestyle change in terms of physical activity. Goal is more than 150 minutes of moderate intensity activity. That is the goal. You may not have to tell your patient, tomorrow you have to go back. Mr. A, tomorrow you have to go back and start your 150. Each patient is an individual. So in your assessment, you got to discuss with them. If those who are sedentary, start with something. Be active in daily life. If they are sporadic, encourage them to do more. If they are already doing, like I know some of the panel here are already doing, please continue doing.
Thank you very much. What about Winnie?
Much of what Ming Yong has said as well. I think similarly with physical activity is also like diet. The key thing, I think my message would be that we have to see lifestyle and eating a healthy diet as an investment. It's not something that you may not see an effect immediately. And I think that's why we take it for granted, right? And by the time we realize it, it's too late. The weight has gone up, the prediabetes has set in, the cholesterol has already gone up already. So we have to start from young, and we need to emphasize on healthful dietary pattern. Sometimes we overemphasize on keto, on low carb, and then we forget the bigger picture. So for me, the bigger picture matters. So if you eat a healthful diet, relatively low in calories, you balance that with your physical activity, get enough sleep at the same time, I think that is the way to go, right? So we mustn't lose sight of that.
Absolutely. Absolutely right. So I think just to again repeat what the lifestyle is diet and physical activity. That is the dominant thing that we want you to take home with. But if you fail, Navin is here. What would you like to say?
Okay, it's not that. Even as a pharmacist, I would actually, advocate lifestyle modification first, because the evidence, even with what I presented, there's strong evidence for lifestyle to actually, reverse, diabetes, right? So, but then there's also, this lifestyle modification. Also from the trials, we see that, people, it will just go up like this and then later come down. It also depends on a lot of factors like motivation and all that, right? How long they do it, and whether they are being coached and all that, right? So when you already reach that level that you need a drug, then yes, you have to initiate the drug. Why we are worried about that is because we know that in pre-diabetes also you can have complications start setting in. Yeah. Complications, macrovascular or microvascular complication can start to come in much earlier, right? Even before the diagnosis of diabetes. So we are worried about that. So if let's say the lifestyle modifications is insufficient and the patients are not getting to target, you see the fasting glucose is more than 6.1, the A1C going into the higher, then maybe I think it's wise to actually start the drug therapy, because what you aim for is to reduce the complications of diabetes. Our patients actually, most of the time, they die of chronic complications of diabetes rather than just the high sugars alone. Very few. I think most of the time they end up, in a hospital for DK or HHS, they get saved. Okay, but mostly it's the chronic complications that we are worried about, which also happens with pre-diabetes. So just be wise when to start the drug. I think its choice is yours.
Thank you very much. I think we're going to go to the post-test questions and ask you to answer them. Please do so. And I think, I'm not sure exactly how this works, but do we do all 9 first and then ask them to answer? Do all 9 first, okay? Nope, let's do all 9 at one go, and then we'll ask the panel to discuss. Okay, so question number 1, obviously I'm not going to repeat lah, huh? Okay, answer.
Oh, now it's 100% all correct.
Okay, we are seeing the answers coming through. Okay. Wow, pretty. Okay. Is it slowing down already? Okay, done. Next question. Next question is all are correct except one. So all are true except one is false. Please answer. Okay, this one is more predictable. Oh no, still got a lot of about 20-30% each. Walao eh. Except one, huh? Okay, my goodness.
Okay.
Okay. All right. Okay, done. Next question. Okay, this one, you should get this right. I asked her for the answer. Oh, yo. That means you guys were not listening.
Information overload.
Overload, alamak. Okay. All right, I think this is done. Okay, move on. Winnie's. Okay, which of the following diet is recommended? This one. Ouch. Okay, that is better. This is better. Okay. Are we slowing down in the response? Okay, next question. Which is true about dietary intervention? Okay? Please answer. I'm seeing two, I don't know why I'm seeing, they're all moving one.
Some of them may have missed certain parts, I
yeah.
think. They may have joined later and missed certain
Yeah,
lectures.
that's true.
Yeah.
So, all right. Okay, now question 6. Which will not ensure sustainable? What is not sustainable? Okay. All right. All right. That one. Okay, then question 4. 7. What the hell? Hypoglycemia setting in.
Yeah.
Which is false? This one, Naveen, you're very naughty lah. Okay. All right, I think
tricky.
maybe now they should be able to answer.
Yeah.
Okay. Alamak. Okay, question 8. Which is true? That means the others are false. Ayoyo. Okay, last. Okay. Which is true? That means the rest are false. Okay. Let's have a look. Better. Letter.
Yeah.
Okay. All right, so I think we're done. Okay, let's have the pre and post test, how you guys did or didn't do, and then ask the relevant speakers to discuss it. Please, can we have the pre and post test, how they answered? Well, okay. Can see,
Can't see. Can't see the question.
Yeah. There.
Okay.
Okay.
Almost the
The first question
Almost the
is
same.
from me.
It's yours.
Yes,
Okay.
that's right. So the answer is
Not
to
much change, Okay, maybe can we ask you to show us which is the right question? That means what we are seeing on this one.
okay. If somebody who is newly diagnosed, whose BMI is 30, and have since left school for 33 years, live a very sedentary lifestyle. So to get the person to engage in the physical, to start physical activity, the answer is to get him to move first, to increase his daily physical activity first, and not to start any exercise program. Because if you do that, the success rate for them to sustain it is less likely. So sedentary, long time, BMI big, just increase your daily activity, such as using staircase instead of elevator, park your car far away. So post test is about the same.
So the answer is B, is it?
Yes.
Dr. Tan?
Yes.
Okay. So question number 2. Question 2. Question 2 is if we can have
To
question
have
2
it-
come
yeah.
up on our screen. Thank you.
Okay, to empower people with pre-diabetes in adoption and maintenance of exercise, all the following are encouraged. Of course, you should choose exercise that is enjoyable, start slow and gradually increase. That is self-efficacy. And then identify and discuss what are the barriers. So for people who are overweight and obese, when you talk about weight with them, it's a very sensitive issue. So we have to encourage them to exercise, not for weight loss, but exercise is to contribute to their general well-being and just to encourage them to have possibly believe that except one, is not to encourage them that exercise is going to contribute to the weight loss, but rather for general health and fitness. Because for overweight, for weight reduction, correct me if I'm wrong from Prof. Ini, exercise only contribute 30%, whereas 70% is through your mouth.
Yes. Yeah.
It helps.
You
It helps.
guys, you
Definitely.
didn't hear us, we just said MCO, no exercise also got better, right? So, I think, apart from the joke, exercise for weight loss is double the amount of what we talked to you about. All right, half hour, 5 days a week is for physical health, physical well-being, cardiovascular fitness, but for weight loss, you got to double that. Okay?
It's 60 to 90 minutes.
60 to
with weight
90
loss.
90 minutes, that's right.
So sorry lah, guys. Not to say we don't want to encourage it, but don't give them the wrong understanding. Where they say, I exercise, well, how come my weight still sama? Right? Okay, right. Thank you. Question number 3.
Well, we have given you the answer just now. It's 2 to 9%.
Okay. All right. I think that one is okay. We'll go to question 4. Winnie, yours.
What was the
Let's
question?
see how they did.
Okay, this is about what's the dietary recommended intervention. All right. For pre-diabetes, so I think I didn't quite cover intermittent fasting, but A and C is definitely out. I mean, high fat, low carb, that's not the way to go. DPP shows low fat actually because you want to get that energy density down, and fat has higher calories than carbohydrate or proteins. And for intermittent fasting, actually I saw a question just now about it. Intermittent fasting does work for weight loss. Yes, it does. But what the evidence is showing is that in the long term, the weight loss is not any better than low-calorie diets. So that's what it means. So it doesn't mean intermittent fasting doesn't work. It's what you eat within that window is also important. So the weight loss may not be it's not higher than low-calorie diets, okay? So essentially, the best that's more sustainable is actually a low-calorie deficit diet that's more helpful and not irrespective of their micronutrient composition. So the calorie still matters. So if you look at the results there, it improved
got
in terms
better.
of the correct answer.
Yep, you did better.
Yeah. So
All right.
next one. Let's look at question 5, dietary intervention for
That's
prediabetes. Okay, so it's very clear that that plain water I think I emphasized it a few times, so you all
Yeah.
got it right. Yeah, swapping the rice with white bread, they're actually of equal amount of it's not about the glycemic index there. Both rice and white bread have similar glycemic index. The rest, not to eat rice, skipping meals, these are all not sustainable, and actually it causes you to eat more in the next meal. So that wouldn't be the way to go.
Absolutely. Compensatory overeating.
Yes.
Next.
Next question. This is about strategies that it's not gonna ensure sustainable lifestyle again. Now, I guess here is a bit tricky. If I can just explain that a bit, I probably didn't think this through properly when I sent this question. Yes, monitoring and coaching does help with sustainability. Multi-component, as you saw, is one of the key one that works. One-on-one counseling, it depends on how frequent we see them. The thing is, you need to see them more frequently. If you say come back in 6 months, that's very unlikely that there'll be major change. Okay, so that's why B is not the answer. I mean, it's the answer that it's
I think
not.
it's just very human resource
And very
intensive,
intensive, correct.
and many
Correct.
sort of like units and whatever cannot
sustain
that.
it, that's
Yeah,
right.
okay.
Yeah.
All the others are
More
useful.
sustainable, yeah, more useful.
Okay.
Yeah.
Now, Naveen, your turn.
Yeah. Let's see. I know it's all a drug part with the trials and all that.
Yeah.
Can be a little bit exhausting. But okay, for this question, which of the following about pre-diabetes management is false? Of course, the answer is D. Okay, because I think the point here is that the DPPOS study showed that the onset of diabetes can be delayed more with metformin than lifestyle modification. Remember the the slide that I showed that actually greater reduction actually with lifestyle modification instead of metformin, right? Lifestyle modification can delay diabetes by 4 years, whereas metformin only by 2 years. So that's the answer. And the rest I think are all false. Okay, I think some of you answered acarbose as well. Yes, I think acarbose can be used to treat pre-diabetes. I think my question is in the Malaysian context with the take-home messages that I mentioned just now using the Malaysian consensus. I think it is stated that we go with metformin when lifestyle fails, right? Next. Which of the following about pre-diabetes management is true? Okay, so the answer actually is C. Acarbose reverse impact glucose tolerance to normal glucose tolerance in the Stop Needham study. Okay, why A? Okay, many of you went A. The Indian Diabetes Prevention Study showed that lifestyle modification and metformin combination were associated with a more significant reduction in diabetes with either intervention alone. Remember when I showed the graph, I think they were all in grey colors. They're all almost the same. Actually, they are not really different. Okay, they are almost the same. So either in the Indian study, either you use the lifestyle arm or the metformin alone, or lifestyle combined with metformin. They all almost came to the same amount of reduction in diabetes incidence. Okay, that's why A is not the answer. It's not superior. Okay, the rest are all I think false. Yeah. Next. For question 9, okay. Which of the management, okay, this one I think is this is what we hope that you get the point here. This is about the Malaysian consensus. So the answer is C. An obese pre-diabetes individual is a better candidate for metformin than a normal weight pre-diabetes individual. I think in my concluding slide, I've already stated that those who are higher risk of pre-diabetes, right, I think those who have overweight and obese, okay, with high BMI, they will respond better to metformin rather than a normal weight pre-diabetes individual. Okay, the rest of it are all false because GLP-1 is not the first line. Metformin can be initiated concurrently with lifestyle. No, not necessarily. You can start with lifestyle first. D is not the answer because metformin in pre-diabetes should be no need to keep it at 1,000 milligram OD, which means only 500 BD, right? You can go up to 1 gram BD, okay? In pre-diabetes as well, like, like diabetes, right? And lastly, I think this one, some of you might have heard, I think it's a bit tricky. Recently, we know that metformin, actually long-term treatment with metformin causes B12 deficiency, which actually results in a lot of other issues like peripheral neuropathy and all that. So I think, of course, to start, supplementation of B12, I think is also good. So that's why it's not the answer. Yeah. Thanks.
Right. Thank you very much, all three of you. I would like to perhaps ask those of you who are still following us to please answer the feedback poll. I'm going to ask you guys to answer a feedback poll because your feedback is important to help us perhaps draft the next sessions. For those who couldn't join us or perhaps only joined half of it, we'll try and send you the video once it is sort of cleaned up a little bit. So, and please look out for the next change, which is the workshop, which will actually take you through hands-on, in a way, how you deal with specific scenarios to help your patients deal with prediabetes. So it's enhancing prediabetes management. It'll be a face-to-face workshop. It'll be a relatively smaller number, but certainly look out for it. It's going to come. The date is not quite fixed, but it is definitely coming. So stay tuned, right? For those of you who want to claim CPD points, here you are, all the QR codes and how to claim your points. And again, while waiting for you to try and claim your points, we'd like to thank the speakers, Dr. Naveen, Professor Winichi, Dr. Tan Ming Yong, for spending their Saturday with us. We thank you too for joining us during the Ramadan month. And yay, we got a bigger crowd than Prof. Mafauzi. Yeah. Right. Thank you for joining us. And take care. See you again. Bye.
Bye.
Done.